Finance Committee will come to order. And before we begin today's hearing, I particularly want to thank my colleagues on both sides of the aisle for the exceptional participation yesterday on the infrastructure hearing, because I thought we got a lot of good ideas out, heard from senators on both sides, and I want to thank my colleagues. Today, we're going to turn to another important area. And I particularly want to thank our ranking member, Senator Crapo, because he and I have been talking about telehealth, talking about a variety of ideas that the committee could work on in a bipartisan way. And we thought in particular, it made some sense to, as part of our duties, from time to time, step back and take a look at what happened during the pandemic, areas where we can do better, ideas where this committee can lead with bold changes, and particularly in the healthcare area, prevent dramatic disruptions of healthcare in our country. We all understand that when COVID hit, it was no longer safe to meet face-to-face, take a bus to the doctor's office, even in many instances, walk into a hospital for care. So when we talk about changes and what ought to stick around and we ought to build on post-pandemic, Senator Crapo and I both thought that telehealth was an ideal way to start. Now, the telehealth challenge has always been about balancing the speed and efficiency of new technologies with the need for healthcare quality and accountability. During the pandemic, some patients have felt that they had to jump through too many hoops, too many bureaucratic challenges in order to get access to telehealth. My view as a general proposition is that patients ought to be able to have more accessible opportunities for telehealth, and particularly after they've seen a provider for the first time, we ought to be able to work together to clear out the bureaucratic hoops so they can get access to telemedicine. In some cases, the right approach may in fact be to give the green light for telehealth from the get-go at the very beginning. So we're looking forward today to discussing how to go about striking that balance after a year of experience during the pandemic. Just so we ever get back to the question of the history here, the committee led the effort to shoehorn coverage for telehealth in Medicare as part of the CARES package. That was a particularly important part of CARES because it allowed healthcare providers in Medicare to offer telehealth services to all older people, regardless of whether they lived in big cities or small rural towns. And that particularly badly needed healthcare measure provided care safely into the homes of tens of millions of seniors nationwide. The CARES Act also allowed federally qualified health centers, including community health centers and rural health clinics, to receive Medicare payment for telehealth services, which meant that still more healthcare providers could be involved in stepping up, as they did, to provide assistance, particularly for healthcare services that would otherwise be very remote and possibly beyond the reach of millions. Now, again, for just a short bit of history, the Finance Committee actually paved the way for a lot of those changes in Medicare, because for years we pressed the case on a bipartisan basis to update the Medicare guarantee and to, in effect, say, you know, Medicare wasn't like it was in the days when I was director of the Gray Panthers. It wasn't primarily an acute care program any longer. It was a chronic care program. And so we led the effort to update the Medicare guarantee. And for too many years, the Congress simply fell behind in terms of recognizing the transformation of the flagship healthcare program at the federal level. And telemedicine is now, largely because it was kicked off by work done by the Senate Finance Committee, telehealth is going to be a big part of the transformation going forward moving beyond acute care and to dealing with chronic disease. The Chronic Care Act, which was passed by the committee when Orrin Hatch was the chair, marked the very first time seniors, for example, could get telehealth at home for kidney disease. The law also made it easier to use telehealth to diagnose and treat strokes. It allowed more flexibility for Medicare Advantage plans and accountable care organizations. So when the pandemic hit, because of the work of the Senate Finance Committee, the Centers for Medicare and Medicaid Services already had a head start for telehealth. I'd also like to mention, as Senator Crapo knows, we've had a number of colleagues in the Senate who've been interested in the telehealth issue, and I want to particularly commend Senator Schatz and Senator Wicker, who also have spent considerable time on this. So federal agencies have taken advantage of existing law to provide providers care to allow providers to care for their patients in fresh ways. For example, certain hospital doctors and nurses were able to travel out into their communities and provide services at home that would typically be reserved for inpatient care. Others could set up temporary spaces like tents near hospitals themselves. They weren't allowed to do this pre-pandemic in ordinary times. So these steps have increased capacity, kept patients safe, helped maintain care. Today, we're going to hear from physicians and hospitals who've been on the front lines and healthcare experts who have seen how the fresh approaches I have just mentioned transformed care. And as we've indicated, there's bipartisan interest in building on these changes that work for seniors, providers, and can allow us to use Medicare, and particularly the telehealth breakthroughs, as a model for other parts of the healthcare system. At the end of last year, we also made progress on legislation that lets seniors in Medicare receive mental health services via telehealth, including at home. My view is mental health services ought to be available via telehealth for all Americans. That provision was part of a bill that I authored that would also permit telehealth for routine healthcare visits in Medicare, known as evaluation and management. I believe the committee can work together on a bipartisan basis to make that and other changes a reality. Let me recognize Senator Crapo and again express my thanks for his partnership in making sure that we got this issue front and center, and we're starting to look at how to build on the lessons of the pandemic. Senator Crapo.
Thank you, Mr. Chairman. Thanks for holding this important hearing. Congress and the administration provided certain healthcare flexibilities during the pandemic so that patients could continue to receive high-quality care. Making permanent changes based on these lessons learned is a top priority. I've shared my interest with President Biden's nominees for the key healthcare positions that have come before this committee, and I appreciate their commitment to work with us on this committee. Republicans and Democrats often disagree on the best way to achieve our shared healthcare goals. This hearing, however, highlights an area of common ground. In fact, Senator Wyden and I asked the majority and minority staff to jointly plan this hearing, demonstrating strong bipartisanship. Acting on legislative changes and using administrative authority, the Centers for Medicare and Medicaid Services waived over 200 payment rules during the pandemic in Medicare alone. Needless to say, there is a lot we can learn. Today's witnesses will provide insight into our efforts that we need to take to evaluate these flexibilities. Hearing firsthand about the patient experience during the pandemic from providers who overcame challenges to provide care will be invaluable. Understanding how the flexibilities are used in fee-for-service, Medicare Advantage, and alternative payment models will be insightful. Much of the hearing will focus on care provided during the pandemic through telehealth. Telehealth has been a lifeline for patients and providers, especially in the early months of the pandemic. The reliance on telehealth increased in rural and urban areas alike, allowing patients to receive remote care from the safety of their own home. Telehealth services have been especially useful for Idahoans. According to the Idaho Department of Insurance, telemedicine visits went from an average of about 200 appointments per month to 28,000 telehealth visits in April 2020 alone. To ensure financial stability, providers have been paid at the same rate as if the service was furnished in person. This has facilitated care that otherwise would be risky or unavailable, and patients have appreciated the convenience. It has reduced the frequency of missed appointments and assisted provider investment in the infrastructure needed for remote care. This long period of expanded telehealth will help us understand the impact on quality of care and program costs. It serves as a robust test project on a scale few could have imagined. The promise of telehealth is clear, but it is important that we gather evidence on its impact on access, quality, and cost. There are approaches to providing care in the most efficient setting that go beyond telehealth. Some hospitals are using a waiver that provides flexibility to triage patients who present to the hospital to see if they can be best cared for in their home. Whether through telehealth, hospital at home, or other innovative care arrangements, it's important to find ways to get patients care that best meets their needs and at the lowest cost possible. Congress has taken permanent steps to do just that in recent years. Nephrologists can conduct remote evaluations of patients receiving home dialysis. Providers can administer certain drugs to vulnerable patients in their own homes. Hearing from our provider witnesses helps us to continue down this path. The Government Accountability Office will supplement what we hear from our provider experts, offering a perspective on how to track and evaluate flexibilities in Medicare and Medicaid as we chart the right course forward. I fully expect that we will take what we learned from this hearing to continue our bipartisan efforts to help providers give patients the best care possible. Permanent changes based on lessons learned from the pandemic to modernize our Medicare system payments and systems lends to the pressing needs to address Medicare's financial struggles. Identifying smart reforms that make Medicare more efficient will be better for patients and better for taxpayers. Such changes alone will not put Medicare on a sustainable path, but they should be a part of that broader conversation. Addressing Medicare solvency should be a bipartisan issue, with time best spent determining how to shore up the current system instead of expanding it to a broader population. Finding the right path on these priority issues is important to patients and the health programs in the committee's jurisdiction. This hearing will help us to capitalize on that bipartisan opportunity. Thank you again, Mr. Chairman. I yield back.
Thank you, Senator Crapo, and I especially appreciate the focus on smart reforms. And if we tie smart reforms to the whole notion of updating the Medicare guarantee, then I think we've really done a service in terms of the healthcare debate, and I thank you for it. We've got virtually every member of the committee signed up to ask questions after we have the witnesses. So we're going to have a particularly busy morning, and we're just going to move ahead. Our first witness being Ms. Jessica Farb, Director of Healthcare at the Government Accountability Office. She has an extensive portfolio there. Then we'll hear from Dr. Keisha Davis, a family physician and a member of the American Academy of Family Physicians Commission on Federal and State Policy. She's also Vice President of Health Equity for LDAID and cares for patients at a primary care clinic in Baltimore, Maryland. So we thank her. We then have Ms. Linda DeSherry, a geriatrician and palliative medicine physician who serves as the clinical director of Mount Sinai, part of the Mount Sinai Health System in New York. After that, we will have Dr. Yanu Murali, a nephrologist and the executive director of the Marshfield Clinic in Wisconsin. And finally, we'll hear from Dr. Robert Berenson, who we've had a chance to work with often over the years, an internal medicine physician and Institute Fellow at the Urban Institute, who is an expert on health policy, particularly Medicare. So I'd also like at this point, and I think we'll not have any objection to this, to enter into the record by unanimous consent, a statement from the Medicare Payment Advisory Commission, or MedPAC, into the record on pandemic flexibilities in Medicare. Hearing no objection, we'll make that part of the record. We'll go right to our witnesses. And then today, colleagues, because we have so many senators who are going to be asking questions, we're going to have to stick to the 5-minute rule pretty scrupulously, or you'll be eating your cornflakes tomorrow morning when everybody is still waiting to ask questions. Ms. Farb.
Chairman Wyden, Ranking Member Crapo, and members of the committee, thank you for the opportunity to discuss GEO's ongoing work examining Medicare and Medicaid program waivers and flexibilities implemented by CMS in response to COVID-19. We undertook this work as part of GEO's broader responsibility to conduct monitoring and oversight under the CARES Act. To increase access to medical services during a public health emergency, the Secretary of HHS can use several different authorities to temporarily waive or modify certain federal healthcare program requirements. Since the beginning of the pandemic, CMS has issued over 230 waivers related to the Medicare program and approved more than 600 different Medicaid waivers and other flexibilities. Many of the Medicare waivers offer flexibilities for providers, hospitals, nursing facilities, and hospices. They generally were intended to increase capacity at facilities, expand the available workforce and beneficiary access to care, and reduce administrative burdens. As examples, CMS 1 allowed hospitals to provide patient care at non-hospital buildings or spaces, also known as a hospital without walls. 2, created an expedited process for new provider enrollment, including waiving certain criminal background checks. And 3, increased flexibility for providers to treat beneficiaries through telehealth. Similarly, CMS approved Medicaid waivers and flexibilities aimed at addressing obstacles that affect beneficiary care, provider availability, and program enrollment. For example, CMS allowed out-of-state licensed providers to care for Medicaid patients across state lines and permitted virtual patient assessments needed to qualify for long-term care services in Medicaid. The full effects of most of these waivers and flexibilities are not yet known, but CMS has reported some data on the use of telehealth in both programs. For example, over the first 8 months of the pandemic, utilization of telehealth services by Medicare fee-for-service beneficiaries sharply increased from about 325,000 services per week at the start of the pandemic to a peak of about 1.9 million about a month later. Since then, utilization has slowly declined, and as of mid-October was slightly over 700,000 services per week, still much higher than pre-pandemic levels. This utilization varied in a number of ways, including by service type, provider specialty, and beneficiary demographics. For example, telehealth was used more frequently for mental health services and by beneficiaries under the age of 65, as well as those located in urban areas. CMS has also reported variation in the use of telehealth in the Medicaid program across the states and across age groups within states. The waivers and flexibilities implemented in Medicare and Medicaid during COVID-19 likely benefited providers and beneficiaries, yet determining whether and if so how to continue them post-pandemic warrants consideration. Factors to consider include program spending, program integrity, beneficiary health and safety, and health equity. Both the Medicare and Medicaid programs are on GEO's high-risk list, in part due to concerns about fraud, waste, and abuse. Telehealth and other waivers pose some risks of unnecessary program spending. The lower but stable telehealth utilization trend we saw last fall in Medicare suggests that demand for telehealth may continue after the pandemic. Medicare currently pays the same for telehealth and in-person services, and one provider group we interviewed cautioned that this could create incentives for specialties that can provide and be paid for both in-person and additional telehealth services to generate telehealth visits without obvious clinical benefit. In addition, the lack of complete data for oversight and suspension of some program safeguards may have increased program risks. For example, CMS lacks complete data to determine the telehealth modality being used, audio only or audio video, or where the services are originated. Important information to consider given payment incentives and the lack of evidence so far about the quality of telehealth services in Medicare. Extending or ending waivers and flexibilities may affect beneficiary health and safety in unknown ways. For example, expedited processes for provider enrollment in both programs, including waivers of normal screening and criminal background checks, could affect the quality and safety of care provided to beneficiaries. And finally, the health disparities we've observed during the pandemic also extend to beneficiaries' access to services and may be exacerbated by differences in access to things such as technology used to support telehealth in rural areas. Thus, health equity may be an important factor in decisions on the continuation of these flexibilities. Careful contemplation of the benefits and risks of continuing these waivers and flexibilities will be key to determining the path forward. We look forward to working with Congress and this committee as we continue our oversight of the federal response to the COVID-19 pandemic. Chairman Wyden, Ranking Member Crapo, and members of the committee, this completes my prepared statement. I would be pleased to respond to any questions that you may have.
Thanks very much, Ms. Farb. Let's go now to Dr. Davis.
Hi, good morning. Good morning, Chairman Wyden, Ranking Member Crapo, and members of the committee. I am Dr. Keisha Davis, a member of the American Academy of Family Physicians Commission on Federal and State Policy, and I'm honored to be here today representing over 133,000 physician and student members of the AAFP. I'm a practicing family physician providing primary care to patients in Baltimore, Maryland, and I also serve as Vice President of Health Equity at Aledade, working to reduce health disparities in physician-led ACOs across multiple states. I've experienced the impact of COVID-19 and resulting federal policy changes firsthand, as well as through the shared experiences of the physicians that I support. I'm appreciative of the flexibilities granted due to the public health emergency. These have allowed all patients, especially some of the most vulnerable, isolated, elderly, and disadvantaged patients, to maintain a relationship with their trusted primary care physician, while many offices had to close or severely limit in-person visits due to social distancing restrictions. It has also allowed these practices to remain financially solvent, whereas their mass closure would have been devastating at a time when medical care was needed most. Lastly, the ability to connect with one's trusted primary care physician via telehealth helped to alleviate the burden on emergency rooms and hospitals. As a physician myself, I want telehealth to be a tool in my toolbox that I can deploy based on clinical judgment, not based on whether I get paid. As Congress considers whether to extend these flexibilities beyond the public health emergency and how to build upon recent advances, it is vital that Medicare and Medicaid policy changes are designed to advance health equity, protect patient safety, and enable clinicians to provide the right care at the right time. To this end, I suggest the following 4 recommendations regarding telehealth flexibilities. First, Congress should permanently remove Section 1834N, geographic and originating site restrictions, to ensure that all Medicare beneficiaries can access care at home. Expanded access to telehealth visits has allowed me to observe my patients' home or work environments, identify factors that may be affecting their health, and develop more personalized treatment plans. While some worry that telehealth will cause patients to become disconnected from their doctor, I have seen just the opposite. For patients, telehealth enables timely, first contact access to care while building and maintaining long-term trusting relationships. I have numerous examples of physicians ensuring patients were still getting the preventive care they needed by conducting annual wellness visits via telehealth, the monitoring and treatment of chronic diseases such as diabetes and hypertension, addressing acute concerns, and most notably conducting transitional care management visits done post-hospital discharge aimed at preventing readmission. Prior to COVID, coming into the doctor's office after being hospitalized was often a barrier. Providing these services for patients in their home increases accessibility for patients who may be homebound or lack transportation and creates opportunities to engage distant family and caregivers. Eliminating geographic and originating site requirements is essential and improves utilization of high-value care and patient outcomes. Second, Congress should require Medicare to cover audio-only E&M services beyond the public health emergency. It is vital to ensure equitable access to telehealth services for patients who may lack broadband access or be uncomfortable with video visits. For many of our patients, especially rural, low-income, elderly, and non-English speakers, voice calls are simply the most accessible option. Payment should support patients' and physicians' ability to choose the most appropriate modality of care, whether it be telephone, audio, video, or in-person, and ensure appropriate payment for care provided. Third, Congress should ensure the permanent equitable coverage and payment of telehealth services provided by community health centers and modify existing payment methodologies to provide timely, appropriate payment for telehealth. Community health centers have been stalwarts during the COVID-19 pandemic, providing testing services, remaining open during staffing shortages, and now leading in vaccine distribution, while ensuring quality of care for millions of low-income persons. Fourth, policymakers should monitor the impact of telehealth and on access and equity and invest in infrastructure to promote digital health equity. While the rapid expansion of telehealth has yielded many benefits for patients and clinicians, not everyone has benefited equally. To achieve the full promise of telehealth, Congress must proactively address structural barriers to virtual care. Additional studies to inform the direction of permanent telehealth policies should include the collection and reporting of data stratified by race, ethnicity, gender, language, and other key factors. Thank you for the opportunity to discuss with this committee the impact of these flexibilities on family physicians and the AAFP's recommendations for permanent policies to advance accessible, equitable, high-quality healthcare beyond the pandemic.
Dr. Davis, thank you. You said so many sensible things. I especially appreciate your bringing up and advocating for the voice calls because I heard that repeatedly again and again. Thank you. Our next witness will be Dr. Linda DeSherry, a geriatrician.
Thank you.
There she is. Good.
Chairman Wyden, Ranking Member Crapo, and the member of the Senate Finance Committee, it is my distinct pleasure on behalf of the Icahn School of Medicine at Mount Sinai and the Hospital at Home Users Group to be part of this panel to discuss hospital at home, specifically extending the current acute hospital care at home flexibilities being offered under the public health emergency. Hospital at home is a patient-centric model of care which provides hospital-level care at home for patients with select acute illnesses who would otherwise be hospitalized. Multiple hospital at home studies have demonstrated improved patient safety, reduced mortality, enhanced quality, and reduced cost. It was a model that many Medicare Advantage, commercial, and Medicaid managed care plans already covered before the pandemic. Adding the rest of the Medicare beneficiaries allows equitable care and has been extremely helpful since November 2020, when the acute hospital care at home waiver was approved. I believe the coverage of hospital at home or acute hospital care at home should be covered beyond the pandemic, preferably as a 30-day bundle of care. In 2014, Mount Sinai applied and received a Center for Medicare and Medicaid Innovation Award to develop and test hospital at home for fee-for-service Medicare population. From this work, we submitted a proposal to the Physician-Focused Payment Model Technical Advisory Committee. The PTAC recommended our proposal in 2018 to the Secretary of the Department of Health and Human Services for implementation. The Secretary expressed interest in testing home-based, hospital-level care models, but no payment model was advanced for beneficiaries in fee-for-service Medicare. In 2017, when our CMMI award was finished, our hospital at home program was no longer able to provide care for fee-for-service Medicare patients, as there was no reimbursement and the program shifted to focus on Medicare Advantage, commercial, and Medicaid managed care plans. We believe congressional action to extend the current waivers and flexibilities is necessary and particularly valuable for patient care. During the initial surge of COVID-19 in March of 2020, we were an important part of helping the Mount Sinai Health System open up more capacity for patients needing higher levels of care, such as ICU, by completing acute care at home for patients already hospitalized. However, we were still unable to admit fee-for-service Medicare patients from the emergency department. We were very excited to be part of the original group of hospitals approved for the acute hospital care at home waiver in November 2020. In addition, we formed a hospital at home users group with the support from the John A. Hartford Foundation, which provides technical assistance and office hours to other hospitals seeking to respond to the waiver. To date, there have been 129 hospitals approved for the acute hospital care at home waiver, with 56 health systems in 30 states, all since November. This shows that there is great interest. However, it does take significant startup resources and time, and many hospitals are not planning to launch until this summer. I believe even more hospitals would implement hospital at home if they knew this program would be extended or made permanent. Therefore, we request Congress and HHS to consider a permanent extension of the acute hospital care at home waivers beyond the PHE to mitigate the residual impacts of COVID-19 on the public health and to encourage broader adoption of providing patient-centered healthcare services in the home. Thank you for the opportunity to present today.
Thank you very much, Dr. DeSherry. Next will be Dr. Murali.
Chairman Wyden, Ranking Member Crapo, and members of the committee. I serve as the Executive Vice President of Care Delivery of Marshfield Clinic Health System. What I'm advocating for and firmly believe is that permanently supporting the telehealth flexibilities created in response to the COVID-19 pandemic and broadband particularly in Middle America, will combat rising cost of healthcare in America and its economic impact on both patients as well as their employers. The potential that telehealth infrastructure has to transform American healthcare system and advance equity, access to healthcare, as well as prosperity for all Americans cannot be understated. It is my honor and privilege to testify on behalf of America's Physician Group. APG is a national professional association representing 300 physician groups and their members that approximate to 195,000 physicians that provide care for nearly 45 million patients across coast to coast. Our vision is to transition from legacy transactional fee-for-service reimbursement to a capitated, value-based system where physician groups are accountable for the total cost of care, the quality of care that they provide for their patients, and are incentivized to innovate and provide the best possible care. Marshfield Clinic Health System is one of the nation's largest fully integrated systems serving predominantly rural population in the state of Wisconsin. Our 1,400 primary care and specialty providers provide approximately 3.5 million encounters annually. Our primary service area encompasses over 80% of Wisconsin's rural population. In fact, over half of our 60+ clinical sites serve populations of less than 2,000 people. We have more cows than people. Our mission to provide healthcare over a large area greater than the state of Maine led to the genesis of our telehealth program in 1997, when we performed heart and lung exams over internet. Today, we use telehealth for hospital at home care, acute care, heart failure care, dental screenings in schools, and much more. We were one of the first hospitals in the country granted Hospital Without Walls waiver by CMS. This because we were already providing hospital level care in the comfort of our patients' homes since 2016, using telehealth even when there was no form of incentive to do so. We knew that for subsets of our population, there is no place like home for inpatient recovery. Compared to matched hospital cohorts, we saw our patient satisfaction increase by 22%, hospital readmission decrease by 44%, length of stay decreased by 37%, and ER visits half. Together, this created a 15% cost savings per episode per patient for the health plans. Since the outset of the pandemic, APG physicians have adopted a lifeline of telehealth, ensuring access to care for our patients who were terrified to leave their homes. In 2020, MCHS provided 250,000 telehealth and telephone encounters. Presently, we average about 15% of all encounters. Telehealth is here to stay. It is convenient and economically beneficial for patients as well as employers. Our patients are older, sicker, and poorer than average in the state of Wisconsin as well as in the nation. Almost half our children are eligible for reduced or free lunches. Public transportation is virtually non-existent. Our patients are geographically isolated and travel 2 hours in treacherous winter weather to come and get essential care. Such obstacles deny care. Telehealth addresses these disparities, ensuring proactive care, reducing ER visits, as well as advancing equity and access to healthcare and stabilizing the economy. My heart tugs at the story of a 67-year-old diabetic woman who I managed for heart failure as well as kidney disease back in 2007. Since then, we managed her care virtually, except for one visit in a year. For the last 13 years, every year, she has sent me a Christmas card. Telehealth has the power to become the norm of this country. We are at a critical juncture at this point. Here are some obstacles. First, given our experience with the current waivers, the site of service restrictions are no longer justifiable. The location of a physician or a patient should not deny care for a patient. Second, the greatest obstacle for patient satisfaction is access to broadband or internet that is stable. Our patient appointments are taken by patients in schools as well as in library parking lots. It would be important for us to focus, at least as a stopgap, to use phone care for risk adjustment in Medicare Advantage people. Our members agree with that restricting care denies care. Finally, and most importantly, permanently reviewing and renewing the telehealth waivers, including acute care without walls, will trigger commercial insurances to go faster. And again, thank you for your service as well as the support. But I would like to share this in the historical context. The US Congress has acted decisively in the past, creating great infrastructure like the Hoover Dam, the Tennessee Valley Authority, and the highway system. We look forward to continuing to work with you in advancing America's healthcare. Thank you.
Thank you, Dr. Morales. I can tell you millions of Americans would be clapping for your proposition that with respect to healthcare, there's no place like home. So thank you very much for your valuable testimony. Dr. Berenson.
Thank you very much. Chairman Wyden, Ranking Member Crapo, and members of the committee. Telehealth offers the promise of an important disruptive innovation in healthcare delivery, improving access and quality while reducing spending. However, decisions on how to pay for expanded use of telehealth will determine whether that promise is achieved. As a practicing internist, the government official in charge of Medicare payment policy at CMS, and now as a policy researcher at the Urban Institute, I have spent much of my professional life exploring better ways of paying health professionals. I have also worked on Medicare payment issues as the vice chair of MedPAC and as an initial member of the PTAC, which was established under the MACRA legislation. On PTAC, I often argued for a straightforward fee schedule change rather than the proposed alternative payment model to achieve the purpose sought. My objections to some alternative models are that they are not operationally feasible. The converse is the case for telehealth. Fee-for-service for telehealth is not operationally feasible as long-term payment policy. I will briefly outline three major reasons. First, fee schedules function reasonably well when the code descriptions are concise and clinically relevant, producing reliable and accurate coding. Codes for telehealth services are anything but concise. Telehealth code descriptions specify the specific modality employed, the patient's location during the communication, which party initiated the service, the duration of the virtual encounter, and a range of other specifications for each code that was described as part of the telehealth expansion. These coding parameters were established for payment purposes alone. They are not useful clinically. Using the standard fee schedule to pay for telehealth services would likely produce a quagmire of confusion, inadvertent or intentional miscoding, and lots of clinician and patient complaints about burden and counterproductive rules. Second, for many telehealth services, fee-for-service payments generate high billing costs relative to the payment actually received. A recent study found that the cost for billing and related documentation for an office visit was more than $20. And that is just the billing cost for the first submitted claim from the practice. A typical claim bounces between the practice, the Medicare contractor, the supplemental insurer, back to the practice, and then to the patient for applicable cost sharing. Proper and fair payment levels will often be lower than the billing costs. So they either won't be billed, or even worse, they won't be provided post-COVID. Not raising the fee, yet raising the fees to make it financially worthwhile, as under pay parity, would ignore the 30-year process for setting relative values in Medicare. Paul Ginsburg, who's the current vice chair of MedPAC, and I wrote that process needs to be changed, but it should not be changed on an ad hoc, one-off basis, just for telehealth. Third, patients face substantial time costs and inconvenience in traditional travel, waiting rooms, actual time with the clinician. I recently waited 20 minutes after my annual wellness visit just to check out. My time commitment for the visit was 3 hours. Patients will often prefer virtual visits, but without any breaks on demand and spending, especially if paid fee-for-service at parity. RAND researchers found in a pre-COVID period that 90% of telehealth services were additional services rather than substitutes for in-person services. Used properly, telehealth often should be add-ons, such as for chronic care management, but also for lots of other sound clinical reasons. And those communications can certainly be done by telephone calls in many cases. Those add-on services need to be managed by the practice within a spending constraint to help assure that virtual visits are used appropriately. CMMI has developed a primary care alternative payment model called Primary Care First. The approach needs to be tested in an expedited fashion on a regional mandatory basis, in my opinion. It has the potential to be the permanent payment model for primary care practices generally, while also addressing payment for telehealth services. My written testimony also provides initial thoughts on using lump sum payments rather than fee-for-service to practices for specialist use of telehealth rather than fee-for-service. So in conclusion, I would just suggest that this is an important time and a real opportunity to fundamentally examine how Medicare pays physicians and other health professionals, and it should not be just sort of a default, let's just continue the current payment flexibilities and high payment levels without full consideration. Thank you very much.
Doctor, thank you. And we have virtually every member participating, so we're going to have to stay pretty close to the 5-minute rule today, colleagues. My first question really speaks to the question of balance. We love the speed and efficiency of new technologies like telehealth. And at the same time, Dr. Berenson just mentioned, we've got to ensure quality care and accountability. And he described this horror story of bills just bouncing from place to place to place. So we're going to have to move around in terms of questions. I think I'll start with our GAO person and Dr. Berenson on this. What are the lessons learned from how we did telehealth during the pandemic for striking this balance that I described as speed and efficiency and quality and accountability? Why don't we start with the GAO person, and then we'll go to you, Dr. Berenson.
Sure. Thank you, Chairman Wyden. I think what we've learned so far is that we don't have complete information that we need to study what we need to study in order to make some determinations about some of the issues that Dr. Berenson was raising. I believe that is why MedPAC actually recommended that some of these flexibilities continue with some guardrails in place so that we can study the effects of these issues on the quality of care, which is still not quite known in Medicare at this point, and on sort of program spending and provider and beneficiary behavior.
Dr. Berenson. You're muted, doctor.
Okay, I'm on. I'll make 2 points. One is that we learned that if you simply pay what the sort of process for generating relative values and fees that has been used in Medicare, you won't get the services you're desiring. In 2019, Medicare CMS put into effect something called a check-in visit, which was a payment to physicians to call their patients to discuss whether they needed to come in for for an in-person visit. The payment by the traditional method was about $14 and change. And guess what? Nobody did the visit. It was less. The practices aren't stupid. They may have made the call, but they sure didn't bill for it. And I would suspect that many practices didn't even do it because of the inadequate payment. So as within the 2 weeks of announcing that there would be a whole new list of telehealth services, the CMS raised that payment level from $14 and change to $56. And guess what? Doctors did it. And I think it was a very smart move by CMS to get money out the door to beleaguered practices who suddenly saw their revenues decrease dramatically and patients couldn't get care. So the payment level matters a lot. And so that's one point. The second point I want to make is that, actually I'm blanking on what my second point is, and so I'll move on.
Thank you. Let's go to the equity question. And by the way, all of you can give us additional information for the record. I just felt that this question is striking. A balance is what practitioners and patients are always asking me. They want the speed, they like the efficiency, but they want the quality and they want answers to these kinds of questions. So apropos of what we heard from GAO, we'll be interested in more information, for example, on your work apparently in the guardrail kind of area. Question for you, Dr. Davis. We have said in our work on this committee, every single time out, we're going to focus on equity issues because we know in America, much of healthcare is really a desert for vulnerable people. If you're affluent and you're white and you're in the suburbs, you got the world in front of you. If you're in the BIPOC community, very often these options just pass you completely. So our first work was on maternal mortality, but we want to make sure that the principles of fairness extend to new technology as well. wave your wand and tell us a couple of things you think you'd be doing if you were on the Finance Committee to promote racial equity in telehealth.
Thank you, Senator Wyden. That's a great question, and it's a concern that we have as well. From what we've seen from the pandemic is that there has been unequal access, and the communities that have been most likely to access telehealth have been whiter, richer, more urban, and with more access. And so I think the first thing is really, as we are exploring and expanding telehealth, really being sure to make sure that the data that we collect is stratified by race, ethnicity, gender, language, and other key factors, making sure that we are taking customer and patient reviews into account as we are expanding outward, and then also continuing to invest in infrastructure, in broadband for our rural communities, for our underserved communities, making sure that they continue to have access so that we are not inadvertently creating a two-tiered system where some have access to in-person and some only have access to telehealth.
Very good. I'm over my time. Senator Crapo.
Thank you much. Thank you very much, Mr. Chairman. I'll start with you, Ms. Farb. The waivers have clearly been successful in increasing patient access. The impact of telehealth on the quality and cost of care is more complicated to measure, as you've indicated. Focusing on the quality part of the equation, what metrics do you use to measure the quality of telehealth services, including in comparison to in-person care?
Well, Chairman Crapo, Senator Crapo, sorry. Thank you for that question. Organizations like the NCQA and NQF have been working during the past year to retool their quality measurement sets and the frameworks that they use to develop quality metrics specifically for telehealth. The key areas that NQF has noted include things like the timeliness of care, which obviously, you know, telehealth may have an advantage in that regard. How well it encourages care coordination, and patient empowerment and engagement. So there's a number of different metrics and sort of categories of metrics along which the quality organizations are suggesting telehealth be measured. We at GEO have not yet looked into specific quality measures for telehealth yet. We've been asking about that as part of our ongoing work to try to understand how providers and others are viewing that.
All right, thank you. And Dr. Murali, it seems the ideal way to deploy telehealth is for a physician working with the patient to decide which care modality works best for each patient visit. But payer policies related to billing, documentation, and payment play a large role in the extent that providers offer telehealth. Understanding that physicians provide the same level of patient care regardless of the type of insurance, is telehealth more feasible in a capitated payment arrangement? You're muted. Oh, there you go.
Senator Crapo, thank you very much. Absolutely. Transactional fee-for-service does not help people to innovate because it's transactional. If you need transformation, you need prospective payments. Capitated payments allow the physician groups to focus on what's important, as well as invest in the infrastructure required to provide optimal telehealth that is integrated in the electronic medical records. As shared in my documentation, presently, physicians have worked as heroes. They do the video chats, the e-coms, as well as all of the transaction while they're doing telehealth, but the systems are not optimally designed to get efficient care. So if you want to get the efficient care and the adoption at a much higher rate, that's absolutely necessary, and you're right on.
Oh, thank you. And Dr. Berenson, could you comment on the same question?
Agree.
Again, you're muted.
Oh, I don't know who's muting me. In any case, I agree very much with Dr. Murali. Capitation doesn't, the problems that I described in fee-for-service, where you have all these rules and requirements as to the circumstances that you have to follow in which you can bill. In my practice, I found often a 2 or 3 minute phone call follow-up the week after I either made a tentative diagnosis or changed the medication was the proper way to follow up with a patient, yet that wouldn't qualify for payment under fee-for-service. With capitation, you've got essentially an account that can be deployed to appropriately use capitation without artificial rules and regulations. to use telehealth without artificial rules and regulations. So I think that's the way to go. CMMI has actually developed a model which is sort of half fee for service and half capitation. It seems like with expedited testing, it could within a couple of years become a national model for moving primary care practice. It's a little trickier to figure out how to pay specialists for their telehealth because capitation's not easily done for specialty services.
All right, thank you. And back to you, Dr. Morali. We've talked about broadband and some of the infrastructure aspects of getting this issue resolved. You stated that telehealth was a fundamental element of caring for patients in rural Wisconsin even before the pandemic. And can you speak to how Marshfield Clinic made the necessary investments in infrastructure and physician training to make that possible?
Yeah, so some before the pandemic, some during the pandemic. Before the pandemic, we invested on optic fiber cables along with our communities, roughly $250,000 in Marshfield, to expand the capacity to provide that service, invested in a standalone data warehouse, as well as focused on trying to get the intelligence required for providing good care with quality and outcomes that are measured. In addition to what needs to be done, so if you want to provide telestroke coverage or ER coverage, or you want to do hospital at home, you need to invest in equipment and platforms that translate to roughly about $4.5 million a year for us as a health system. And so we've been doing that without any concern because there is no way to optimize labor of difficult to recruit physicians and provide the care in populations that are less than 2,000 in a 45,000 square mile geography. And so
Thank you very much.
Absolutely out of necessity.
Doctor, thank you. With 26 senators waiting to ask questions, we are going to move quickly. Senator Stabenow.
Well, thank you very much, Mr. Chairman. And, you know, I've been smiling this morning as I'm thinking back to when so many of us were pulled together before the CARES Act was put together. And at the time, Senator Thune and I were charged with getting together to make some recommendations, bipartisan recommendations on Medicare. And we quickly came together around telehealth. And of course, the committee embraced those recommendations. And I'm just so pleased that we were, all of us together, willing to move forward on telehealth, and I support yours and the ranking members' desires to make these things permanent. Certainly dealing with the issues around accountability that we need to do. So when we look at the issues around telehealth, I wanted to specifically ask about mental health and addiction services. We did include these areas for behavioral health clinics to be able to use telehealth, as well as community health centers and others. And while we're seeing that there's been dramatically expanded access to telehealth, CMS reported a 2,700% increase in telehealth utilization for Medicaid and children's health insurance beneficiaries. That's amazing. But in behavioral health treatment for Medicaid and for CHIP, actually at the same time, it dropped dramatically overall during the pandemic, 22% for adults and 34% for children. So we definitely want to move ahead and do what we need to do to strengthen all these policies. But I do want to ask Dr. Davis if you could speak to the mental health addiction services piece of this and what we need to do to be able to make sure we're reaching out to everyone who needs help, because obviously in this space, we are not reaching people.
Thank you, Senator Stabenow. Yeah, telehealth for mental health and primary care is so important, and it really can help remove barriers to access, to stigma, in terms of patients who may be hesitant to, set out and meet somebody in person, and being able to see them face to face. That makes a huge difference. The practice that I work in, we have a strong connection with mental health, and so it has been absolutely beneficial to our patients to be able to provide them with behavioral health services through telehealth. We also provide addiction services, and so being able to provide substance use disorder and MAT treatment through telehealth has been essential for our patients. I can't explain why we haven't seen the increase that we might have expected, but I can tell from patient experience that it is an essential service.
Thank you. And let me take my last moments just to ask Dr. DeSherry about home health, more about home health, because we know that as we're expanding eligibility for more people to get care at home during COVID-19, how important that was. And many Medicare beneficiaries can now receive that care at home that they would previously have had to travel or risk exposure to be able to receive. And we know that home health care helps in many different ways. But Dr. DeSherry, could you discuss the benefits to meeting patients' needs in their communities, including at home when medically appropriate? Just a little bit more about why you think it's important that we focus on that.
Yes, thank you for that great question. So I provide care both in hospital at home, home-based primary care, home-based palliative care. So I believe in multiple models of home-based care that all have their place and have really increased their need during this pandemic, where patients want to be home and get that care at home. So yes, I think all of those are things that should be thought about how to expand.
Thank you. Thank you, Mr. Chairman. I'm going to yield back 30 seconds for the good of the order.
Thank you and for your good work. Senator Grassley is next.
Thank you, Mr. Chairman. Glad to be with you. A very important issue. Lessons learned from the pandemic. Probably still going to continue to learn a lot. Thank you very much. So I'm going to ask questions of panelists pretty much. So if you can save some time by not repeating each other, I'd appreciate it. So my first question to the panelists is, while the pandemic has shown many flexibilities in healthcare take place without compromising patient safety and quality, there are still areas in healthcare that are restricted by federal laws and regulations. I've sponsored the Pharmacy and Medical Underserved Areas Enhancement Act with Senators Casey and Brown. This bill would let pharmacists operate in a medically underserved area, offer health services like wellness screening and diabetes management, and be paid by Medicare. For each of the panelists, which additional flexibility should Congress consider to improve patient access and remove federal red tape?
Senator Grassley, if I may.
Yes.
At this point in time, at the Marshfield Clinic Health System, we do about 53,000 to 55,000 telepharmacy visits, using the pharmacist in one center to help with respect to mixing in a sterile environment all the medications that are required across the remote geography. So promoting programs that will help, like you have, is going to be very, very valuable in this space.
Okay. Anybody else that wants to add, although you don't all have to speak if you don't have something to add?
Sure, this is Dr. Davis. I'll say, I appreciate the extension of pharmacy, and as long as that's done as part of the medical home, I think that's important. Speaking of other flexibilities beyond telehealth that should be considered, one is Medicare and Medicaid coverage for all AAFP, also ACIP required recommendations, not just the COVID-19 vaccine, but access without cost sharing beyond the public health emergency. In addition, allowing physicians to provide direct supervision and teaching services via real-time, two-way audio-video communication, which would expand access to primary care and increase training opportunities. This has already been done in rural areas, but extending that to all communities. And then permanently removing or reducing the volume of prior authorizations, step therapy, and other administrative requirements, and allowing those to be done via telehealth or in person.
Okay. Since you brought up telehealth, I'm going to go to my next question. It's really a positive thing, I think, that has resulted from the pandemic. If you want to say anything good can come out of a pandemic. The public health emergency permitted more than 140 services to be administered through telehealth. Last Congress, we made mental health services beyond by telehealth a permanent Medicare benefit. For each of the panelists who are physicians, telehealth was widely adopted throughout the pandemic, with its current utilization greater than pre-pandemic, but less than its peak last spring. What type of medical services are most utilized today through telehealth, and which ones are most effective for patients and provider? And maybe the last half of that question is the most important part of it.
Senator Grassley, so from the standpoint, I heard Senator Stabenow's comment. In the Marshfield Clinic Health System, the number of behavioral and psychological consults that go through telehealth has more than doubled compared to the average. So more than 30 to 40% of our visits are actually for behavioral health visits for substance abuse as well as other elements. So that's an important factor from the standpoint of telehealth. I will yield to the rest to comment.
Okay.
I will just make a brief comment on that as well. I'm going to agree again with Dr. Morelli about the role of behavioral health by telehealth. I was involved with interviewing primary care physicians, nearly 20, and they all said, even though they're not specifically behavioral health physicians, that has been the biggest uptake and the most valuable thing that has occurred. The only issue that I can raise there is some families, there may be a confidentiality issue where we're doing the telehealth when the patient's at our home, but that can usually be worked around. I don't think there's a comprehensive analysis yet of which services. We heard anecdotally, for example, that hypertension was good to manage by telehealth because patients had their own blood pressure machines and could take their blood pressures, whereas diabetes, the patient needed to come in for a blood test to check their hemoglobin A1C, and this will evolve over time. I think, however, that for the most part, virtually all general medical and surgical, well, not surgical, which needs a procedure in many cases, but general medical issues can be dealt with with telehealth being a central part of the management strategy.
Thank you, Mr. Chairman. I'm going to submit other questions for answer in writing.
That'll be fine. Senator Cantwell, Chair of the Commerce Committee and a tech expert.
Thank you, Mr. Chairman. Thanks for having this hearing. If I could just get a quick yes or no answer from all the witnesses, do you think we need more affordable healthcare options for people in America?
Yes.
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 Thank you. Ms. Farr, one plan that is out there that could help reduce the cost is the Essential Plan in New York, or better known as the Basic Health Plan from the legislation. It has allowed people under 200% of the federal poverty line to see huge savings in their costs. Should we be doing more to drive the value of expansion of this program to other states?
Senator Cantwell, thank you for the question. We have not done any work looking at that plan in New York and at GAO, so I can't really comment on whether or not it should be expanded. I would defer to my colleagues.
Yeah, Dr. DeSherry, you're a New Yorker. What do you think?
I'm also, it's not my area of expertise. I'm sorry, I don't have anything to add for that.
Okay. Anybody else? Okay, so I guess we have mystery here that maybe I can try to illuminate for the future, but I can tell you this. My constituents are tired of subsidizing expensive health insurance plans when we don't have to. If there are ways to buy in bulk, which New York and Minnesota have done, and bundle up a large percentage of the population, then yes, they believe they should get discounts. That's what's happening. So, Mr. Chairman, mark me down as someone who's not going to go along, even if it is a Democratic proposal. I'm not going to go along until we do something about lowering the investments we're making in expensive subsidies to insurance companies for healthcare. This plan has worked in 2 states, and we should be using it as a way to save dollars and expand coverage to more people. Americans cannot, even with our tax subsidies, continue to have expensive health insurance costs. Okay, great discussion on telehealth. Really appreciate all of that. The University of Washington has gone from doing about 20,000 people a year to 20,000 a month. And I'm curious as to Dr. DeSherry or Mr. Benson, what do you think what else do we need to do to change the actual reimbursement rate? So does it have to be on exact parity? Can it be a little off of parity? What do we need to do to make sure the reimbursement rate is there? Or is there something else we need to do to differentiate?
I think that's probably Dr. Berenson's field to answer.
Again, my proposal would be that we continue fee-for-service as an interim strategy, and I don't have the magic number for you. If we pay based on the traditional resource-based relative value scale approach, the payments for the low end of telehealth would be too low to actually have them perform. Pay parity, where we're now paying 3 times what that sort of proper amount should be, is too high. So I think some smart people could get into a room and come up with some middle ground so that it was high enough that physicians and practices would actually bill it. But RAND has pretty well demonstrated in a prior study, and I haven't seen it challenged, that the costs for telehealth are less than the cost for in-person. It just makes sense. And as telehealth becomes sort of standard in most practices, practices will reduce some of their infrastructure and maybe work with less space, and their costs may come down. But in the interim, I think we can find some middle ground, but it should be in the context that we're moving to something different at some date, if not certain, at least.
Thank you for that honest answer. And do you think that's rocket science, or do you think that's just coming to terms on numbers? And yes, people will obviously have strong opinions, but do you think that that's something we could achieve in the next several weeks?
Next several months. I think we some surveys of practices and get some answers.
Thank you so much. And I don't know if I have any time left, Mr. Chairman. I can't see the clock here, so.
You're pretty much online, but do you have one other one you want to ask?
I just want to say that I hope that Dr. DeSherry could answer some questions, or anything about, we've done, Multicare got a CMS waiver on helping integrate doctor care to home care. So it's basically better ways for the home healthcare programs to work with healthcare providers. And I hope that we could look at that also as a cost savings in keeping patients in their homes longer. So thank you very much, and we'll write something for the record on that.
Great. And Senator Cantwell, I want everybody to know I'm with you all the way on this proposition that states ought to be given the opportunity to be able to do more to hold down healthcare costs. And I think you said it very well. Senator Cornyn is next.
Well, thank you, Mr. Chairman. We all know that in an effort to maintain adequate capacity in our hospitals and doctors' offices, we limited the amount of elective procedures that were performed to deal with the potential surge of COVID-19 patients. And as a result, a lot of healthcare screenings, colonoscopies, other life-saving diagnostics were dropped dramatically. We know that about 1/3 of adults have not received recommended screenings for associated age and risks during the pandemic, and 43% of patients have missed routine preventative health appointments as a consequence of these precautions. Fortunately, now that more people are being vaccinated, hopefully those numbers will improve. But I want to add my voice to the chorus, I guess, here today, of advocating the enhanced use of telehealth. I tell my friends and constituents back in Texas, there are only 2 good things that came out of COVID-19. One is telehealth, and the second is margaritas to go. Those are the only 2 good things I can think of. So let me ask, we're all very familiar with the digital divide, and this is very true, particularly in big states like mine. And we are working on that diligently. Senator Manchin and I have an Eliminate the Digital Divide Act, which will provide grants to governors to help them work with internet service providers to connect underserved areas. But I want to ask the panel about audio telehealth. It seems to me that this could be an interim solution to make sure that low-income earners could get access to a doctor or healthcare advice over the telephone. So maybe starting with Ms. Farb and Dr. Davis, could you explain how telehealth services furnished by audio-only communications could increase access to care, particularly in rural and underserved areas?
Sure. I'll start, and then I think Dr. Davis can speak more fully to this. But what we've observed, and even talking to some of the provider groups we've spoken with, a lot of providers, not only the beneficiaries not having access, providers not having access is also an issue. And so a lot of providers initially started off using audio-only telehealth services, especially for the office visits, the evaluation and management codes, and that's probably continued throughout the pandemic, but in the early days, that was definitely a source of modality that really was working for a number of groups that we've spoken to.
Dr. Davis?
Thanks for the question. I would also echo both the need for audio only is essential for our underrepresented communities, underserviced. We realize that, sometimes broadband is just not there, and we'll try to connect with patients via video, and the resource is just not there. The patient is not comfortable with it. They can't get their smartphone or device to work, or they just don't have one. And as we build infrastructure, we should build it in a way that is mindful of that. I also want to call out specifically around translation services for non-English speaking patients, and that being able to get that language translation is often easier through an audio only visit than it is through a audio video visit.
So Dr. Morali, I see you nodding when I ask about audio only telehealth. What is your view?
So out of the 250,000 or so encounters that we have in Wisconsin, more than 50% of the visits are by audio only. Unfortunately, even Medicare Advantage does not consider it for risk evaluation or adjudication, and that is a bad deal for patients, and it increases disparities. And I think when you think about digital divide as well as racial disparities, we also need to think about the fact that even white people in rural America are poor. They basically don't have access to care. And there's also the question of digital literacy that needs to increase. So all of those are disparities that we have to keep in mind. So right on.
I have time for one more question. One of the concerns we have is about security of specifically personal health information. Obviously, HIPAA provides that, generally speaking. But as we continue to provide more telehealth, I'm worried about the protection of the privacy of the doctor-patient relationship. In closing here, do any of you have any particular observations or experience about how we can make sure that is preserved?
Yes, so I think it is important to invest on the infrastructure for security breach, like what's happening in Ireland right now with Conti is a good example of a security breach. And that can be addressed by infrastructure. And then from the psychiatric care, patients actually prefer to do that from home because it gives them the psychological safety of having that discussion in the comfort of the home as opposed to sitting in a public health waiting room. So those are all factors that should be factored in. And that's why payment parity is necessary to get us moving forwards on this.
Thank you very much, Mr. Chairman.
Thank you, Senator Cornyn, and we're with you on the audio question, particularly if the take-up rate is as low as Dr. Morali said. It's probably even worse when you're talking about traditional Medicare. If the take-up rate is low on MA, think about what it's like on traditional Medicare. So we're going to follow that up. Thank you. Our next questioner, Senator Menendez.
Thank you, Mr. Chairman. Dr. Davis and Dr. Morali, in your testimony, you both highlight the importance of audio-only telehealth. Can you tell the committee a little bit more about why coverage of audio-only telehealth services is so critical to ensure that we don't further fall behind on healthcare equity?
Senator Menendez, I would like to invite you to visit us in Marshfield. And you can go from one location to any of our 60 locations for 2 hours without having access to internet. And the only thing that works is the old-fashioned telephone network. So if you're really trying to address geographic isolation, that phone call is the most critical piece. In the hospital at home program that we started, we were trying to work those pieces back in 2016, and we were looking for 1 bar out of 5 to make sure that we could provide some kind of virtual health. So it is not just the access of broadband, it is also the degree at which broadband is available in these rural areas that cause the disparity. So I hope that answers your question.
Dr.
Yeah,
Davis?
and I would second everything that Dr. Morale just said. The extension to rural areas is so important, and really investment in primary care is helpful in bridging that digital divide so that patients have timely access to in-person care and audio video telehealth. But the audio only is really just essential for getting past some of those barriers, and we don't want to create a two-tiered system, so that we need to make sure that payment is adequate to support the flexibility and modalities of care.
Thank you. Dr. Cherry, building on the previous question, the COVID-19 pandemic did not create inequity in our healthcare system. Inequity is, in fact, a hallmark of American healthcare. What role can telehealth play in addressing longstanding health disparities in our healthcare system?
Yeah, I mean, I witnessed this firsthand in my home-based primary care program, where, again, most patients didn't own a cell phone and had no ability to do any video visits. And we, like Dr. Morale mentioned, we did everything by telephone those first couple months. In my hospital at home program, we actually provide every patient with a telehealth kit. And even here in New York City, one kit that's set up with Verizon doesn't always work with, you got to switch to the AT&T one. Even here in New York City, we have these issues. So to be able to provide care for patients in their home, we need to think through these things and make sure we have all options available.
Ms. Farb, data collection has been an ongoing issue throughout this pandemic. I sent letters to the administration, as well as the last one, about the need for better data collection during the pandemic. I'm disappointed that HHS has still not consolidated data collection into one site with standardized reporting requirements. What data is needed about the flexibilities extended during this public health emergency to show the committee the impact of these flexibilities, and what, if any, flexibility should be made permanent?
We don't have any recommendations yet on any flexibilities that should be made permanent. One thing I did want to point out that might be worth considering as the committee undertakes some of this work is, ensuring that some of the program requirements between both Medicare and Medicaid, looking at how well they align and what are some of the differences, because I think the providers on the panel will probably agree that having two very different sort of sets of rules around how telehealth works can be difficult for them to operate in that environment where they're dealing with that. As far as data collection goes, yes, we've made a number of recommendations during the pandemic around providing better data, as well as ensuring that the data are contained in a site that's publicly accessible on cases, hospitalizations, et cetera. For flexibilities, I think what we don't have is some of the information we need about differences between different telehealth modalities and some of the patient information and demographics that we need, and the sites of care, so that we can look at quality and other things that would be important to measure.
Thank you. Finally, Mr. Chairman, I know we're all committed to building back a stronger health system, ensuring our nation's ready for the next pandemic, and dealing with the inequities in our system. But if we're going to do that, I think one of the most effective and informed ways that we can come together on a nonpartisan basis is to conduct a thorough examination of the United States COVID-19 response, what went right, what went wrong, how we can do it better. That's why we have a bipartisan, bicameral National Coronavirus Commission CARE Act that my friend and colleague Susan Collins has joined me on. I appreciate your support as well, Mr. Chairman, as well as Senator Brown and Senator Kaine. And the House has Representatives Malinowski and Diaz-Balart on a bipartisan basis leading an effort. And I hope we can get that, because I think that would provide us a unvarnished and fair process of understanding what went right, what went wrong. Thank you very much.
We'll be supporting you. Thank you. Senator Cardin is next.
Well, thank you, Mr. Chairman, and I want to thank all of our witnesses. And I want to just join the overwhelming number of our members on lessons learned from COVID-19 about telehealth. But I just really want to follow up with Senator Menendez. It also showed the inequities in our healthcare system. And those communities that don't have the same degree of infrastructure, health infrastructure, or access to healthcare, were the ones who suffered the most during COVID-19. There's no question about that. So it means we have to strengthen that. So as we look at telehealth, which was critically important for mental health, and I hope we go forward with permanent changes in our reimbursement structures and in the reciprocal regulatory issues among states, so that we can expand telehealth, because I think it gives timely access to care for so many individuals. I just really want to underscore the point that Senator Menendez made about not developing a two-tier system. It's very clear to me that as a practical matter, having audio only is better than not having any care. But if we set up a structure that has a two-tier system, that those who have access to high-speed internet or have the abilities to access providers that can provide a much more comprehensive telehealth service, and that other communities that don't have that same degree are given only audio, we run the risk of a two-tier system. And if the reimbursement structure incorporates that, it then becomes also a two-tier system. So I guess my question to all of you is, as we look at the reciprocal regulations, as we look at the reimbursement structures, as we look at access to broadband and not just access to high speed, but the capacity to be able as an individual person to properly access that. Some of our elderly have difficulty with this. What steps should be our top priority to make sure that as we expand telehealth, that we all agree needs to be done, we do it in a way that doesn't set up a two-tier system? I'll be glad to start with Jessica Tharp. If you want to start, whoever wants to start, I appreciate it.
Sure. I think one option that's been suggested, although it doesn't sort of completely align with what the panel's been talking about, is to make sure to cover audio only where there's a documented barrier to audiovisual visits, and look at that for a brief period of time so that data could be collected to study the quality of care and determine the comparability to in-person visits. And as I said earlier, we've heard from providers that they had to, and we've already heard from this panel that they've had to resort to audio only when the patient didn't have access. And as you pointed out, Senator Cardin, just having something is better than nothing. So trying to do some kind of targeted study of differences would be one way to try to make sure that we are giving comparable care.
Dr. Davis?
If I could go next.
Sure.
I haven't had a chance to say this yet, but I'll take this opportunity. I actually got interested in how to pay for telehealth after Professor Ed Wagner at the University of Washington, who I'm sure the chairman and Senator Cantwell know, proposed his chronic care model. And the chronic care model included, I wrote in 2003, it called for robust use of telephones. We didn't really have video. I think video is being hyped a little too much here. In many situations, such as chronic care management, you only need a few minutes with a patient. You've already seen them either in person or through a video conference, and you want to be checking on how they are doing. We created in Medicare a chronic care management code, but that's for very sick people who need really intensive care management. Most patients with hypertension or diabetes or congestive heart failure will benefit from a follow-up phone call. And so my view is that the phone calls are the encounters that take place for minutes. The video visit is for something longer, like an annual visit, or for something that really requires 20 or 25 minutes and where visual contact is necessary. And that would, I think, help a lot on this on the equity issue. I think phone audio only, as it's being called, should be equal. And that was one of my points, is that the coding is sort of arbitrary, and so I'll pose the question: is a Zoom call with the video off, is that an audio only, or is that a defective video call? I mean, I
think I'll just underscore Mr. Favre's point. It'd be good to have a study as to the how audio works. Obviously, follow-up conversations with healthcare providers is one thing, but to do a diagnostic type of interview, it's a lot of times easier and more effective to have video. Anyway, I look forward to that study, and thank you, Mr. Chairman. Excellent hearing.
Thank you, Senator Cardin. And I will tell you, Dr. Berenson, you're spot on with respect to the history on chronic care. Senator Hatch and I always conceived that there would be a significant audio/phone component of it, and that's what we really envisioned in the first part of the bill. Okay, Senator Portman, I believe, is next, if he is there. Senator Portman, you out in cyberspace somewhere? Senator Brown. Senator Cassidy, a physician. Senator Bennett. Who's ready? Senator Langford. I do see Senator Whitehouse on the screen, and he's not even on our list, but we have no other senators. So let's have Senator Whitehouse, who is a very knowledgeable person on healthcare. Senator Whitehouse.
Thank you, Chairman. Every once in a while, you get lucky and can jump the queue. I just wanted to pass along to the panelists the success that Rhode Island has had with these waivers during the COVID pandemic. We have made very good use of the Hospitals Without Walls program, and I'd love to see that continued. We kind of broke the back of opposition to telehealth generally, and I don't think there's really any going back on that. It's been particularly welcome in the behavioral health, mental health, addiction area, where practitioners report to me not only better compliance with showing up and participating, but also better substantive content. It's hard for them to quantify that, but it's a repeated theme that there's something about being able to talk from your own home, from a comfortable place, rather than having to drive across town and fill out the clipboard and sit in somebody else's office. It just seems better. And the medication-assisted treatment element and allowing, access to buprenorphine, for instance, with telehealth has been a godsend for that population. And the last thing I'll mention is that I've been working for a long time to try to get CMMI to sign off on a bunch of waivers to deal with people who are nearing the end of life, for whom a lot of waivers make a lot of sense. It doesn't make any sense to fuss too much about how homebound somebody is at that stage of their life. Home health services waivers that we've seen through COVID are very helpful. Respite care isn't respite if you got a stuffed granny in the hospital and not get help to come to her in the house. And the whole 3-day, 2-night rule is ridiculous for those patients. And those waivers, I hope we can extend. I'd ask Director Farb, with respect to the homebound and home health service and 3-day, 2-night waivers, has GAO seen any evidence of heightened utilization as a result, heightened cost?
Senator Whitehouse, no, we have not examined that directly. We also tried to look to see what CMS has been reporting in there. So far, they've created an accomplishment report sort of describing effects of many of the waivers. They haven't included anything thus far in their reporting, but it's something we're going to be tracking going forward as we start to work on the additional waiver kind of study that we're planning to do.
Good. It's particularly important to me for people nearing the end of their lives because it just doesn't make any sense. It's kind of cruel to the family to deny them those supports because of some funding requirement that is not even designed for that population, but has these terrible effects on families and their access to care. Dr. DeCherry, are you familiar with the Hospitals Without Walls program, and would you like to comment on the wisdom of extending that?
Yeah, I mean, specifically the hospital at home portion of that is what we made use of during this pandemic. I want to also go back to one thing that you mentioned earlier about the comfort of someone in their home. You mentioned in the context of behavioral health, but I would broaden that. When we are in the home, and that could be either in person for our hospital home, the nurses in person in the home, or through the video when a provider might be doing a video visit. Seeing someone in their own context to see what they're actually eating might actually help long-term make real impacts in their lives. And so these little snippets of getting into someone's home have really improved health for people long-term. And so I just wanted to make sure that was understood for the possible.
Let me close out with a little brag on Rhode Island ACOs. We have two Rhode Island primary care physicians, which operates an Integra ACO, and Coastal Medical in Rhode Island, and both of them are absolutely top performing ACOs nationally. I mean, they're right up in the upper corner of savings and quality of outcome and patient satisfaction. And part of what they have done is to engage with patients in their home.
Exactly.
In order to get better information. And that is part of what has made it work so well. I will go as far as you want to go, Dr. Cherry, on this. My problem is I've been jammed up in CMMI for 10 years trying to get it just for end-of-life patients. So that's our beachhead, but I do think a lot more can be done, and the ACOs have shown a lot of good results on that. So I'll yield back because I think I'm probably out of time, but I really appreciate this conversation. There's a lot to be done, and if people at CMMI are listening, I think we gave them these powers for a reason. Let's use them.
Well said. Senator Brown.
Thank you, Mr. Chairman. I appreciated the comments of my friend from Rhode Island, and I know that Senators Cornyn and Menendez asked about audio-only telehealth too. I'd like to follow up with a couple of questions, particularly about folks who live in more urban and suburban settings who may not have access to video conferencing or internet capabilities to access video telehealth. So my question, starting with Dr. Morali, speak briefly, if you would, about the increased reimbursement for audio-only telemedicine, how it helped you stay connected with hard-to-reach populations throughout the pandemic, both in underserved urban areas and underserved rural areas, if you would, Dr. Morali.
Thank you, Senator Brown. So as I shared previously, out of the 250,000 visits that we did at the Marshfield Clinic Health System, greater than 50% of those visits were done by audio visits. And so what it allowed us to do is manage patients with heart failure. In fact, we had studies that demonstrated that we were able to save close to about $2.7 million for managing 600 patients. Just imagine the power of that if you were to take that across the entire country. From the standpoint of behavioral health, I've already made my point about audio, because audio drives pretty much all of what you need to know from the standpoint of that care. So there are several benefits, and that's just a snippet of what audio can do.
Thank you, Doctor.
Yeah, sorry. The other piece is that it is extremely difficult to get broadband access in rural Wisconsin. And so if we do not provide that support on the audio side, you're geographically isolating these patients from seeking the care that they need, and therefore you're not being proactive. And that will increase your emergency care visits as well as your urgent care visits and overall costs from the standpoint of care.
Thank you. Dr. Dechary, I appreciate your comments about nutrition and what the window into homes that can provide and help. Dr. Davis, my next couple of questions are for you. You recommend Congress to act to require Medicare to cover audio-only evaluation and management services beyond the public health emergency to ensure equitable access to care. Talk, if you would, about two questions: how audio-only telemedicine services can help reduce disparities in access to care, and how should CMS monitor the impact of telehealth, including audio-only telehealth, on access and equity?
Sure. Thanks, Senator Brown. You know, as a primary care provider and also working in an accountable care organization, we have lots of experience with this. And audio-only care, when used appropriately, is high-quality care. And so I want to make sure that we put that distinction, that studies comparing telephone-only visits to telehealth visits conducted prior to the pandemic found no significant difference in health outcomes or patient-reported satisfaction. And so it certainly is an additional tool in the toolbox in order to be able to provide equitable care for patients, regardless of whether patients are rural or suburban. I have provided care for those patients. The docs I work with have provided care with those patients, and across the board have had challenges when they are restricted to only video services. And so being able to interact with our elderly patients who may have trouble connecting and not have a family member close by who can help, for our non-English speakers who may have trouble connecting and need translation services, and for those who don't have access to broadband in a robust way, audio only is essential for providing good care for them.
And CMS can monitor the impact of that?
Yeah, I mean, I think, we have coding and ability to do that, paired with patient satisfaction, paired with care outcomes, the ability to collect data. Now, I feel like as a physician, my quality is monitored in many different ways, and getting back to health outcomes. And I think it's important to distinguish that telehealth audio only and with video should be differentiated between what happens and in the primary care patient-centered medical home versus a vendor that is providing just that service. And so audio telehealth is provided best when it is part of the care continuum that a primary care provider is providing. You have the background and the history on the patient, the access to their chart, and that long-term trusting relationship.
Thank you, Dr. Davis. And on my last 30 seconds, Mr. Chairman, and thank you for your indulgence. I wanted to bring up another issue, no question, just an issue Senator Capito and I have proposed related to Medicare's hospice respite benefit. It's the COVID-19 Hospice Respite Care Relief Act of 2020, giving Secretary of HHS the authority to allow hospice patients to receive respite care at home and for longer periods of time during any public health emergency. Including obviously the one we're in. It wasn't able to make it for a difference for family caregivers over the past year. It's my hope the committee, Mr. Chairman, can consider ways to strengthen the hospice respite benefit moving forward. So thank you, and thanks to the witnesses today for your insight.
We'll follow up with you, Senator Brown and Senator Capito. Very important. Senator Langford is next.
Chairman, thank you. Thanks to all of our witnesses and the insight that you're bringing. Thanks for all your work during the pandemic. There's a great deal of work that was done and a lot of innovation that happened at your places to be able to actually take care of people. So thanks for that level of engagement that you had as we work our way through this. There were over 200 flexibilities that were given by CMS during this time period. Congress was obviously very engaged. My office was engaged, as well as all the other offices here in this hearing today, trying to be able to go back and forth on it. We've talked a lot about telehealth, and I want to mention some of those things in a moment. But Dr. Berenson, I do want to be able to bring up an issue about the 3-day rule for skilled nursing facilities. When I called back to touch base with a lot of our hospitals and facilities and such, and to say, of all the flexibilities that are there, which one really stands out as one that needs to last, everyone brought up telehealth, but then this 3-day rule for the skilled nursing facilities came up. Can you talk about that a little bit? You're on mute still.
I apologize for forgetting that I'm on mute. It's been around since the beginning of the program, basically, because of the concern that Medicare would be turned into a long-term care program if you did not have a requirement that skilled nursing was associated with an inpatient visit. I mean, an inpatient hospitalization. It is clear that MA functions very well without the 3-day rule. There are exceptions for ACOs, and there's sort of general agreement that it has a perverse incentive and it involves a lot of gaming. In fact, I have been involved with a family member who was kept an extra day just to qualify for the 3-day rule. So to me, if we can figure out a way to sort of eliminate it without running into the concern that we've created a long-term care benefit, I think we should do so. And the more we sort of move towards risk-taking and capitated type arrangements, where the organization itself has an incentive not to abuse the hospitalization, I think we can make good progress. But I agree with you completely that it is very frustrating. It even affects the observation stay rule in Medicare, where beneficiaries don't qualify because they actually were not in an inpatient stay, they were just in an observation stay, and therefore they don't get the same access to skilled nursing. It really is a problem that deserves real attention.
It's a serious issue. I'd be interested in any other practitioners that have, if they have observations on this 3-day rule.
Sure. This is Dr. Davis with AFP. I would like to second, the AFP would be in favor of reducing that. And just to, share an example from a patient that I had, a patient that I was actually doing home visits on, which is rare, but we still do home visits and could see in his home. He needed a higher level of care, did not need to go to the emergency room or hospital. He just needed to be in a skilled nursing facility to receive some rehab. But in order to get him there, he had to go to the hospital, developed an infection in the hospital, which lengthened his length of stay and lengthened his, raised his Medicare costs. Eventually did end up in the nursing home, but the relationship that I had with that patient, I knew his history, I knew what the appropriate next level was care, and it just created barriers and increased costs that were unnecessary.
Senator Langford, at Marshfield, in 2014, we started our process of creating comfort and recovery suites, got skilled nursing facility bed licenses, and did all of our orthopedic surgery, our gallbladder surgery, our gynecological surgery, thyroid surgeries, and kept them in the SNF for a little longer than 24 hours, and we could send them home. Phenomenal cost savings that can be achieved on the commercial as well as the Medicare Advantage, which we have shown in our data. And so I think it's an archaic role. It needs to be looked at because it causes wasteful spend. The other piece is in the hospital at home, when somebody comes into the ER, you'll end up putting them in an observation bed from the standpoint of 24 or whatever duration of time. If you have the skilled nursing facility option available, somebody comes in the middle of the night, can't go back home, you would prop them up in the skilled nursing facility bed for 12 hours and then make arrangements for hospital at home care at home. So that's what we do in the rural environment, because when you have the little old lady who's 84 years comes into the ER at midnight, you can't possibly arrange for oxygen. It is easier to deliver pizza in Manhattan at midnight than it is to get oxygen delivered to home at midnight. So I think for all of those reasons, thinking about skilled nursing facility differently and creatively is important on a risk-based model. So I'll rest there.
All right. Thank you, Mr. Chairman. Thank you very much.
Thank you very, very much. And Doctor, you really highlighted the importance of care over some other things people are thinking about sometimes. Senator Casey.
Mr. Chairman, thanks very much for having this hearing. It's critically important. A number of issues that we're learning so much about in the last more than a year now. And I'll have a question for Dr. DeSherry and Dr. Davis. The question for Dr. Davis will be about mental health for children and teens, but I wanted to ask you, Dr. DeSherry, about the PACE program and the expansion of it. We're learning so much and exploring today innovative models of care, and I think if there's one thing we've learned over the course of the pandemic is the importance of services that allow seniors and people with disabilities to remain in their homes and their communities, as we've heard over and over again today. And that's, of course, the setting that they would prefer. They prefer to get care in the home or in the community. And like the hospital at home model, which provides hospital level care for people with acute illnesses, the PACE program, or the so-called Program of All-Inclusive Care for the Elderly, we refer to it in Pennsylvania by a different acronym, the LIFE program, is similarly a way that seniors and people with disabilities can receive wraparound care while remaining at home. So I think we've got to take the lessons we learned in the last year and improve and expand upon services like PACE to ensure that seniors and people with disabilities have access to the supports that they require. I've introduced the PACE Plus Act just last month. This would provide funding for existing PACE programs to service more people, and it will allow these specialized programs to expand into areas that don't currently offer PACE as a long-term care option. So, Doctor, I'd ask for your perspective on what's the value of expanding programs like PACE that provide these wraparound services for seniors and people with disabilities.
Thank you for that excellent question. I haven't worked at a PACE program since my residency. I was fortunate enough to get that opportunity to work at a PACE program for an entire year during my residency. And so I have familiarity with the model. But it is very much like home-based primary care, which I do every day. And so I do believe that expanding access for home-based programs, hospital at home, home-based primary care, PACE, is very important. We've seen that here in the pandemic, that patients absolutely want that type of care, and we should act to expand it.
Doctor, I appreciate that. And I wanted to ask a question for Dr. Davis, as I mentioned earlier about children. We know that if there was one problem that was terribly, terribly exacerbated, it was the crisis in mental health, especially for children and teens. And some of the most horrific stories and some of the numbers that are so horrific, I think will stay with us a long time. We're told that, for example, a 24% increase in emergency room visits for mental health crises among children ages 5 to 11, increased wait times to access inpatient mental health treatment, and so much else. And as we recover from the pandemic and the restrictions are lifted, children with mental and behavioral health needs aren't going to be going away. We've got to make sure that we have programs in place and strategies to make sure we have the appropriate care for them. We need to make sure that they have the appropriate treatment and in the appropriate setting at the appropriate time. So, Dr. Davis, are there ways that existing tools or options in both Medicaid and CHIP can be used to address mental and behavioral health needs of children and teens?
Thank you, Senator Casey. You know, as the mom of 3 school-age sons, this is acutely aware to me and the challenges that they've had in virtual schooling and not being able to connect with their friends. And I see it as in my patients as well. So one, the expansion of telehealth for mental health is crucial for children. One of the biggest barriers as a primary care physician was just being able to find a therapist or psychologist, psychiatrist in the area to be able to treat children. And so being able to expand that treatment network is really huge. I think the second is creating parity in payment with Medicaid. Continuing that, and we especially see low reimbursement for mental health providers who are offering Medicaid services. And so if we really are trying to address that divide, we need to make sure that Medicaid is having reimbursement for mental health services, especially for children.
Doctor, thank you. Mr. Chairman, thank you.
Thank you, Senator Casey. Next is Senator Thune.
Thank you, Mr. Chairman and Ranking Member Crapo. I think if we can find a bright spot from this pandemic, the embrace of telehealth across the nation is certainly one. For 4 Congresses, the Senate Telehealth Working Group has advocated for increased access to telehealth. And working with this committee, many provisions from past versions of our group's Connect for Health Act have become law. In fact, Connect informed a lot of our discussions on the CARES Act, which Senator Stabenow already mentioned. So that brings us to where we are today, and I think the question is, what have we learned? Dr. Morale, you represent a health system that utilized telehealth long before the pandemic, like many of the systems in South Dakota have. Do you support the Connect Act, and which provisions in your view are most important to improve access for rural and urban patients?
First, I thank you for co-sponsoring the Connect Act. It is one of the most important acts, especially in the space of rural healthcare, particularly as you took away the requirement for geographic restrictions to allow FQHCs and RHCs to do the work that they need to do. It's one of the craziest rules. So for instance, you have a physician who can see, say, 20 patients a day. They're in a rural center as part of an FQHC or an RHC where there only were 4 patients to see that day. If they need to provide that service in some other remote area, they could not do it if not for the act. So that is a wonderful piece of what that act has achieved, at least in remote and rural parts of Wisconsin. So I hope I've answered your question as to the value of Connect Act. And I think Sanford, which is in your state, has some of the same issues, and they're part of the clinic club, and we spend a lot of time trying to creatively see how we can provide service. So that's my response.
In your testimony, you discussed what could be the quote new norm with telehealth and phone. You predict that 15 to 16% of all appointments per month may be handled this way moving forward. Could you talk to us a little bit more about how you came to that conclusion, and if your data includes both Medicare and commercially insured patients?
First to the last question, answer is yes. So both commercial as well as Medicare patients at this point in time for that calculation. So let me just take a quick illustration. My wife is a pediatric neurologist. She's one of 3 pediatric neurologists in the 45,000 square miles that we provide care. If a mother has to bring her child for general epilepsy care, which is a 30-minute visit, she needs to bundle those kids in winter gear in the peak of winter and travel 2 hours and then back 2 hours for a 30-minute visit, which can be done through telehealth. Like that, there are a lot of established visits that can be done once you have had the first physical visit and can be done efficiently. Think about the impact of that to the employer. Think of the impact to the mother, the cost of driving these kids, paying for their lunches, paying for their gas, and losing 1 day's work that's happening all across rural America. So that's number 1 point. You can extend that E&M visits for dermatology. You can do that for pretty much all specialties in terms of how you can manage that care. And that number is about 15 to 16% in our present numbers and could go up to 20% if we actually are allowed to adopt these services in a creative manner. And that is confirmed by my colleagues in APG who also do some of that same work, and further confirmed when the pandemic happened, when we shut down all services, 22% of all care, even by physicians who were unwilling to do telephone or telehealth visits, was the number that we had in our institution. So it's a phenomenal step if we can go down that direction.
So as Congress continues to discuss which of these pandemic flexibilities should be made permanent, there have been discussions about whether increased program integrity measures are needed, and some have suggested a requirement for a face-to-face encounter. Considering this from a health disparity standpoint, I think we have to be careful about a one-size-fits-all approach that could prevent rural patients in particular from taking the first step to seek care. So as things stand today, is there any reason a clinician couldn't tell their patient that an in-person visit is needed without having a mandate to do that?
Yeah, so all physicians will do the right thing for their patients. If they believe a physical visit is required, we will do it because we have signed the Hippocratic Oath and we want to provide the best care for our patients, and we carry the burden of their sickness or outcomes. So I don't think that is a concern at all. Like I said in my testimony, I manage a 67-year-old lady for complex heart failure at a distance of 200 miles. And she came to visit me once a year for 4 years. And she's even now 13 years after the episode, and she sends me a Christmas card. A lot can be done from the standpoint of how it's provided.
Okay. Thank you, Mr. Chairman.
Carper, right?
Carper.
Senator Carper, I think you're out there somewhere.
That's him. Okay, he's not at his desk.
Okay, we are missing Senator Carper.
Daines.
Let's see. Yes, Senator Daines would be next, and then Senator Warner and Senator Hassan. Senator Daines, no.
There we go.
Yes,
All
Senator.
right. Thank you, Mr. Chairman. Appreciate you. Yeah, touchdown for you. You did it. Great. Thank you. I appreciate this hearing today. And we are a rural state in Montana, and we have faced access challenge to healthcare before the pandemic. And so when folks were told to stay home, prevent the spread of COVID and avoid exposure to the virus, virtual care became even more important. It was a lifeline in many cases for Montana patients. Montanans now are telling me that that test drive of COVID healthcare flexibilities was a success, especially when it comes to expanded access to telehealth. I believe we need to do what we can to make expanded access to telehealth permanent for Montanans and all Americans, especially in rural areas, and not cut access back once we're in the post-pandemic period. Back in March of last year, I introduced the Telehealth Expansion Act to allow American workers and families to access virtual care without the burden of first meeting their deductible. My bill was signed into law as part of the CARES Act, allowing these high deductible health plans with health savings accounts to offer cost-free telehealth services. This ensured patient access to critical care during the pandemic. Today, I'm teaming up with my colleague, Senator Cortez Masto, and we're introducing legislation to make this policy permanent. One of the lessons certainly we learned from the pandemic is the value of leveraging telehealth to meet rising demand for healthcare services. Access to virtual care should not solely be considered a COVID-19 policy. Our legislation, entitled the Telehealth Expansion Act of 2021, will meaningfully expand access to care by permanently allowing first dollar coverage of virtual care under high deductible health plans. My question for Dr. Murali, practicing in Wisconsin, I know you are all too familiar with rural healthcare challenges. Could you speak to the value of reducing barriers to telemedicine and specifically the advantages of making this particular policy permanent?
We actually strongly support that policy. And I think you're talking about your first dollar policy with respect to high deductible health plans. And we believe that that brings immense value to our communities. And if that is expanded to behavioral health and other pieces, I think it is a wonderful thing to do. I have discussed this with our health plan CEO, as well as our folks who are on the ground. And the information I've received from them is it'll be extremely well received from the standpoint of care and providing access to care, which is critical in rural Wisconsin.
Thank you, Doctor. When it comes to accessing telehealth in Montana, our people in rural communities that lack sufficient broadband and internet connectivity do not have the option of that face-to-face virtual care. In some cases, audio telehealth using a phone is the only option. In fact, I just met with some of my primary care docs from Montana this morning. They talked about the importance too of audio telehealth, where we sometimes don't have the visual option. And that's why I worked with my colleagues last year to ensure payment parity for audio-only telehealth, ensuring that rural Montanans can access telehealth no matter where they live and no matter what access they might have. Dr. Murali, how important is payment parity when it comes to ensuring that folks in rural communities can access care?
I think, as I've shared before, there's a lot of investment that goes in the infrastructure to maintain that ability to provide telehealth and actually lower the cost of care. So payment parity is absolutely important from that standpoint.
So expanded access to telehealth services, including physical therapy, has helped our seniors in Montana and around our country who have been the most vulnerable to the virus. It also helped demonstrate that therapy needs to be and can be met with the use of technology, and that patients can have improved access in rural areas particularly. Ms. Farb, what had GAO found when it comes to the value of expanded telehealth, including physical therapy, during this pandemic? And is there evidence that using telehealth has helped remove delays or perhaps barriers to people accessing preventive services that have helped to prevent the deterioration of a patient's condition?
So Senator Daines, we are still working on our study looking at the effects of telehealth on the beneficiaries that have received it. I can say from some of the interviews we conducted with beneficiary advocacy organizations that much of what you just said in terms of serving as a lifeline and serving as a way for beneficiaries to access services that they otherwise wouldn't have been able to do. We definitely have heard that. We will be breaking out some of the utilization, both pre-pandemic and during the pandemic, in terms of looking at some of the data by various demographic characteristics, including urban areas, as well as particular services, as you mentioned, physical therapy and other services that were available. So I don't have any preliminary data yet to share on that, but that is what we are currently working on in our study that we're doing right now.
Thank you, Ms. Farb. Mr. Chairman, thank you.
Thank you, Senator Daines. Senator Crapo is going to help us keep this going. So I believe our next three will be Senator Carper, Senator Warner, and Senator Hassan. Hopefully we can get all three in before the vote. Senator Carper.
Thanks, Mr. Chair. I was out during our last recess, Mr. Chairman and colleagues, I was out in the Bay Area and visited a number of technology companies. Some of them startups, some of them have been around for a while. One of the companies I visited, I think the name was, I want to say Ginger, and they're involved, it's behavioral science, and they work with helping people who have behavioral science challenges in their lives, mental health and so forth. And it's a company that uses telemedicine to try to bring some help to work with people early on in their illnesses. So just this for me is something in real life. Just saw it for myself, and another way I think to get better results, hopefully better results, and for less money, and help people deal with those kind of challenges in their lives. But I very much welcome this hearing today, and during the pandemic, telehealth has been become a more essential a tool in our toolboxes to try to make sure that not just adults but children receive the care that they need while minimizing risk. And although telehealth under Medicare has been a focus, close to 40 million children, I'm told, are enrolled in Medicaid or the Children's Health Insurance Program, 40 million. And across our nation, families experience barriers that prevent them from accessing routine health services, like a limited availability of providers or long wait times for an appointment. And for many in the Medicaid and the Children's Health Insurance Program, increased access to telehealth services can mitigate those barriers to improve the timeliness and convenience of care delivery, while also improving healthcare outcomes, and doing so at reduced costs. I have a question for Dr. Berenson, if I could. What are the main policy changes, Dr. Berenson, that we need to ensure this broader use of telehealth can be continued for children beyond the pandemic? Dr. Berenson.
Well, there's an echo. I tend to be a Medicare expert, but I think basically states need to have generous telehealth policies, but I'm not the person who really can tell you precisely what we should do for children in this area.
Okay, thank you. Anybody else among our panelists would like to take a shot at that, please?
I think this is Dr. Davis. Again, just Medicaid payment for children is really important. They make sure that they have access.
All right, thank you. Anyone else, please? All right, let me move to the next question. And my follow-up question deals with guidance for state Medicaid and CHIP programs. And during the COVID-19 public health emergency, which we're still struggling to get out of, but making progress, a wide variety of policy waivers have been put in place across our country to expand access to telehealth services, unleashing the power and potential of telehealth to safely and effectively provide care to children and to their families. However, there's a wide variation in telehealth policies among state Medicaid programs. And as states consider how to expand coverage of telehealth services, there's a limited guidance or information to aid in their planning. And moreover, there are limited comprehensive studies specifically looking at the impact of telehealth on the Medicaid population, including during national public health. And if I could, Dr. Davis and Ms. Farb, according to MACPAC's March 2018 report on telehealth in Medicaid, states looking to expand telehealth in their Medicaid and CHIP programs would benefit from additional research and a more robust understanding of the impact of telehealth. My question of Dr. Davis and Ms. Farb, do you believe that further study in this space is still needed? And do you think the real-world evidence gathered during the pandemic could provide further insights that support the expansion of telehealth for our children? Dr. Davis, Ms. Farb, please.
Thank you, Senator Carper. There's been a lot of study already, and I think from MACPAC's work and work that we've seen that we can start to move forward and recognize the importance of payment parity for Medicaid, especially for the benefit of our children who are participating in the CHIP program and in the Medicaid program.
And I will just add, we are actually studying telehealth in the Medicaid program as we speak as well. This is my statement today has been based on the ongoing work that we're doing both in Medicare and Medicaid. So we are looking at the effects of the use of telehealth during the pandemic and trying to garner some lessons learned. As far as guidance from CMS, we understand that they are planning to issue some additional guidance to states, but some of that guidance is still in review within the agency. So in our ongoing work, we've talked to CMS about what plans they have to provide that guidance, especially in looking at sort of program integrity types of things that they need to be aware of. So, but we are doing work. So it's hard for me to say we shouldn't study it more. I think given where I sit at GAO, but I definitely think there's a lot of evidence out there, as Dr. Davis pointed out.
We've got an important and let's get Warner and Senator Hassan in before we have to run. And we're going to keep this going. Senator Warner.
Thank you, Mr. Chairman. I will try to make sure I address these in quick timelines. First, I think we all know that obviously COVID exposed some of the racial disparities we see in healthcare coverage. I think this committee and others have tried to do a better job of making sure we get good data on some of those racial disparities. One of the things that I've worked with the chairman and others on is making sure that we encourage states to go ahead and expand Medicaid and that we increase our premium payments. I actually hope on the ACA, I hope we can make some of those things permanent. But Mr. Berenson, you want to weigh in on this issue of whether the expansion of Medicaid in states that were not covered, whether the ACA additional premium payment support that we put in place and some of the legislation recently will actually start to help diminish some of the racial disparities that were exposed by COVID-19? I think you're on mute, Mr. Berenson.
Sorry about that. Again, I'm not a Medicaid expert, but my understanding of the results from Oregon, which had that study where they sort of randomly selected people into Medicaid, demonstrated better access when people did get Medicaid. And I think the outcomes were a little mixed, but the study wasn't conducted long enough to be able to demonstrate those. So I basically agree with the premise of your question. There need to be incentives for all states to adopt Medicaid as an expansion.
Well, thank you. And I think I'm going to obviously continue working with the chairman and others on this. Let me move to a slightly more probing question for Dr. Davis and Ms. Farb. And let me preface this question with, obviously we all realize the opioid abuse and substance abuse issues are a huge challenge, and this committee, again, with folks like my friend Senator Portman, have been grappling with that for some time. On the other hand, I've been trying to get the DEA, literally for close to 10 years, to allow for physicians frankly, for the DEA to promulgate rulemakings, which they are supposed to have done by law, to allow certain physicians to prescribe certain controlled substances via telehealth. We've made sure to make this happen in legislation called the Support Act last Congress. But the DEA continues to refuse to take up this rulemaking. I've reached out to them multiple times on this. I do believe that Biden administration is trying to work in good faith, but with the importance of telehealth being accentuated by COVID, by this panel, Dr. Davis, I'd like to hear from you, given your experiences with patient care, and Ms. Farb, I imagine GAO may have taken a look at this issue as well. I know we want to make sure there's not abuse, particularly when it's coming to controlled substances. But I do think we've been waiting 10 years, and it is in the law. And while we need to put appropriate protections in place, we need to let physicians have these tools. So, Dr. Davis and Ms. Farb, will you comment on that subject?
Sure. Thank you, Senator Warner. I do also want to go back to your previous question, and as Vice Chair of MACPAC, do want to echo that we have already started to see a reduction in health disparities in those states that have expanded Medicaid, and we need to continue to study that and look at and see those drivers. In terms of substance abuse treatment, as a buprenorphine provider myself, I have seen the benefit, especially throughout COVID-19, of being able to conduct those services via telehealth, being able to prescribe remotely and electronically, being able to keep patients from relapsing has been essential, especially with all of the stresses that have happened over the last year. And so encourage continuation and really passing legislation, getting us further along to be able to conduct that service electronically, both in terms of prescription and in terms of the visit by telehealth or audio.
Thank you, Dr. Davis. I agree with you. And again, DEA on some of this rulemaking has just been dragging its feet. Ms. Farb, do you want to make a comment?
Sure. So GAO does have prior work kind of looking at some of the barriers to medication-assisted treatment for opioid use disorder. And we have noted that some of what you're discussing did occur in terms of prior authorization requirements and restrictions on distribution, and then just the federal waiver that providers need to prescribe or administer some of the prescriptions that are needed. So we didn't make any recommendations out of that study, but we definitely did, enumerate all the barriers that are being faced by providers and various healthcare programs.
Well, I hope we can keep working on this. I think I'll turn it back now to, I guess, Senator Crapo, you're filling in. Thank you.
Thank you, Senator Warner. This is great. Let's see, is Senator Hassan's there, and Senator Crapo is back, and I'll run and vote and come right back. But Senator Hassan is up now, Senator Crapo.
Well, thank you so much. Thank you so much, Chairman Wyden and Ranking Member Crapo, for this hearing. I want to echo what Senator Warner was just talking about when it comes to facilitating medication-assisted treatment, and I look forward to working with colleagues on both sides of the aisle on that. And before I get to my questions, I also want to reinforce my colleagues' calls to continue to expand telehealth access, including in rural communities. The dramatic expansion in telehealth services during the pandemic has benefited a large number of patients, including in my home state of New Hampshire. I want to turn now to Dr. Davis. The news that there could be an authorized COVID-19 vaccine for all children by the end of this year is truly an exciting development for many families. However, I'm very concerned that over the past year, routine child wellness visits and pediatric vaccinations have declined significantly, particularly for children enrolled in Medicaid and the Children's Health Insurance Program. Telehealth expansions have improved access to many routine primary care services, but unfortunately, you can't get a vaccination over Zoom. So Dr. Davis, as telehealth becomes more integrated into primary care services, how can we ensure that children will continue to attend routine in-person wellness visits that help ensure that children are receiving life-saving vaccinations, as well as critical developmental and physical screenings? And how do we get children who missed their routine vaccinations over the past year back on track?
Thank you, Senator Hassan. Yes, it's very important. And I do worry about the kids who are delayed in their vaccines because of hesitancy in going into care. But I have seen the resilience in our family physicians, our pediatricians, especially at our community health centers, in getting creative and innovative in making sure that kids are getting their vaccines in terms of, drive-up clinics, parking lot operations, and being able to make sure that they are getting them. I'm not worried that telehealth is going to replace what we do as a physician, and in combination in that primary care relationship, doctors are going to make sure that their kids are coming in for their vaccines and have really seen them being stalwarts and champions in continuing that. I think that there are other things that we can do to encourage vaccines, requirements that happens at schools, to make sure that kids are getting the vaccines. But I'm not worried that there's lots of catch up to do, but I think that we can get there.
Thank you so much for that. To Dr. DeSherry, I want to talk with you a little bit about home and community-based services. The American Rescue Plan increases federal funding for home and community-based Medicaid services. However, while this initial investment is an important step, we need to do more to ensure that older adults and individuals with disabilities have access to this care. Many of us on the committee are continuing to work towards some long-term solutions here, but what changes do you believe are needed to expand the home health workforce and improve the quality and accessibility of home and community-based services?
Thank you so much for this question. We can't, in geriatrics, we can't do what we do without the family support, without the aides who are there to care for our patients. Almost our work is like 1/10 of the daily work that these people do to help support our patients. And it's so important that we're able to support the caregivers. So I agree with you that we need to think about how to expand that workforce, how to make sure that patients are able to get high quality care through that workforce. And it could be through family caregivers or paid caregivers.
Thank you. Is it fair to say that families who can get some support and relief from home care health aides, for instance, often are able to support their loved one better at home than when they try to do it all by themselves?
Yes, definitely.
Thank you. To Dr. Davis, one more question. The COVID-19 pandemic has demonstrated the value of providing critical vaccines to vulnerable populations at no cost. Women covered through Medicaid are less likely to receive their tetanus and influenza vaccines during pregnancy than those who have commercial insurance. Earlier this year, Senator Cassidy and I reintroduced the Maternal Immunization Coverage Act to help address this disparity. This is a bipartisan bill that would ensure that state Medicaid programs cover ACIP recommended vaccines for pregnant beneficiaries at no cost. Dr. Davis, how should we apply the lessons that we've learned from this public health emergency about the benefits of providing vaccines to vulnerable populations at no cost in order to ensure that all Americans have access to life-saving vaccinations?
We've really learned from the COVID-19 vaccination that when you are able to offer it without cost, then that removes a significant barrier. And the AAFP agrees that we should expand access to all ACIP recommended vaccines at no cost through Medicare, Medicaid, CHIP, and all other commercial insurers.
Thank you very much. And thank you, Senator Crapo.
Thank you. And Senator Young is next on the list, but I don't see him on the screen. Is Senator Young with us? All right, Senator Warren, I see you. Go ahead, please.
You see me. Thank you, Mr. Chairman. So when coronavirus hit, patients still needed access to basic health services like primary care and mental health visits, but COVID made it harder for patients to get the care that they needed. On top of the usual struggles like taking off time for work, people now had to keep themselves safe from infection. Services that were already difficult to manage, even in the best of times, became much harder to get. Take hearing loss, which affects 48 million Americans. On average, it takes 7 years for patients to seek treatment for hearing issues, even when we are not in a global pandemic. And COVID-19 only added to additional burdens. So that's a key reason why the Centers for Medicare and Medicaid Services made it easier for providers like audiologists to offer hearing services remotely during the pandemic. Ms. Farb, what steps has CMS taken during the pandemic to make it easier for patients to access care from audiologists through telehealth during this pandemic?
Well, Senator, as you pointed out, CMS initially expanded the types of providers that could furnish telehealth services to include all those eligible to bill, which included physical therapists and speech language pathologists, as well as audiologists. At the beginning, they were able to bill for certain codes starting in March of 2020, and some of those codes are not typically the codes that are billed by audiologists, but CMS added additional codes to the list at the end of March of 2021, and that coverage was effective retroactively back to January of 2021. The list included services such as tone decay tests and assessments of tinnitus, and so that expanded sort of the ability for audiologists to provide those services. We spoke with ASHA, the association that covers speech language pathologists as well as audiologists, and they were very supportive of those changes.
Right. So, Ms. Farb, if I can just summarize, CMS considered audiologists to be important enough to include in the response to the pandemic. But audiologists usually aren't treated equally in the Medicare program. Despite their years of schooling and training, audiologists are considered, quote, suppliers, not, quote, practitioners in the program. And outdated Medicare rules require patients to get their doctor's permission to see an audiologist rather than letting patients make the decisions they need to improve their hearing. So let me ask, Dr. DeCherie, why is it so important that seniors with hearing loss can access the providers they need, including audiologists, without bureaucratic limitations that make it harder for them to get care?
Thank you for that question. Yes, I mean, being able to hear is so important, especially for our elderly patients. I mean, there have been numerous studies that have shown reduced risk of falls, improved mood, improved memory, all by being able to hear better. I mean, we see this every day on, home visits now when we're trying to do something by video. If they can't hear, just turning up the volume doesn't work. So these patients really do need their hearing assessed, and then potentially a hearing aid or whatever is needed.
Right. In other words, audiologists provide critical services to people with hearing loss. That's why I'm joining Senator Paul and Senator Grassley in reintroducing the Medicare Audiologist Access and Services Act. This is a bill that would expand seniors' access to hearing services by reclassifying audiologists as practitioners in the Medicare program, and that will allow them to bill for services without a physician referral and to provide patients with both the kind of diagnostic and treatment services that are within an audiologist's scope of practice. It seems to me that the COVID-19 pandemic has forced us all to reconsider bureaucratic limitations to healthcare, including hearing care. So I believe that the Senate should prioritize the passage of our bill to help seniors get the care that they need. Thank you, Mr. Chairman.
Thank you, Senator Warren. And I see Senator Cortez Mastos. So Senator, you may proceed.
Senator Crapo, thank you. And thank you to the panelists. This has been a very, very informative conversation. And let me echo and agree with my colleagues. I think making telehealth permanent is so important for the reasons that we are discussing today. But I also recognize and really appreciate the challenges that we still need to understand the data. We need to capture the accurate data, the diversity in the data. We need to make sure we put up guardrails to still study it. But for the many reasons we talked about, I think it is so important. I've seen the benefits in Nevada alone. But here's one thing, and we've talked about this already this morning, is audio only diagnostic information. I absolutely have concerns that we are not allowing the diagnostic information for audio only to occur. This is information that I've been talking to the CMS about. And so because I think it is so important we address this, and clearly my colleagues feel the same way after listening to the conversation this morning, Senator Tim Scott and I introduced a bill, the Ensuring Parity in Medicare Advantage for Audio-Only Telehealth Act. It would really require CMS to include diagnosis obtained via audio-only telehealth visits in a Medicare Advantage risk adjustment program. And it is so important for the very reasons that you talked about. So I want to get that out there. But let me also, Dr. Davis, let me ask you this. In your experience, are patients with high deductible health plans more or less likely to seek regular treatment?
In a pre-public health emergency, I certainly saw patients who were hesitant to come in because of the high deductible health plans and just not being able to afford it. The AAFP supported the temporarily waiving the deductible for telehealth visits because the investment was necessary for providers to really be able to make that investment in telehealth. We are concerned, though, with the permanent waiver of that and the possibility of creating a two-tiered system where low-income enrollees are only able to afford virtual care. And so we recommend that the committee pass legislation to allow high-deductible healthcare plans to waive the deductible for primary care and mental health services, both in-person and telehealth, to promote timely access to high-value care and preserve patients' freedom to choose the most appropriate modality of care.
Yeah, I couldn't agree more, and I thank you for that. And so let me jump to Ms. Farb. There was conversation about identifying high quality of telehealth services. And I know you were asked whether GAO has, what were the metrics they were looking at? And you said that GAO hadn't defined yet the metrics for identifying the quality of telehealth services. Can you give me a timeline? Is this something that is a priority now for GAO? And is this something you will be further looking into, or GAO will, in identifying those metrics?
Yes, Senator. So as far as identifying and creating the metrics, that's a role that GAO does not play. We rely on the institutions that are sort of responsible and contracted with HHS, such as the National Quality Forum, to develop consensus-based quality metrics. And as I mentioned earlier, both the NCQA, another quality convening organization, and NQF have been working this past year to sort of adapt some of the metrics and frameworks that they use to incorporate telehealth, the concept of telehealth, and focusing it on, you know, things that are clinically meaningful for patients and providers to measure quality. So that's sort of what we're waiting on, is to see what these other institutions are going to do in terms of how they're going to define quality. There are ways to compare particular endpoints and outcomes that you could compare telehealth to in-person care, but that's still a ways away for us in terms of our work that we're doing right now.
Well, thank you. And so then let me jump to Dr. DeSherry, because I think it is important. When in your testimony, you really talked about that acute hospital at-home waivers, and particularly the front-end costs of getting things started, whether it's telehealth, acute hospital at-home waivers, whatever's needed, that the hospitals were not making some of these investments long-term because they weren't sure if the waivers will become permanent. And I guess my question to you is, what is it that you need from us at a federal level, or you would think that the hospitals need to really be thinking long term, that we want to move in this direction, short of passing legislation?
Yeah, well, the hospital at home waiver came about last November. And obviously, we don't know exactly when the public health emergency is going to end, but it's tied to the public health emergency. Right now, that date is July. And so making an investment now for a program that might end in July, that's a big decision for a hospital. Making the waiver permanent for another year or another 2 years, or extending the waiver while things are being analyzed, I think that would be one way that would entice the hospitals to apply for it.
Thank you. Thank you again. Thank you to the panel members.
Thank you, Senator Crapo, for filling in. It's gotten to be a tradition. We juggle all of this. Senator Young, I believe, is next. We're moving into the home stretch, colleagues. If members have not gotten a chance to ask questions, we're putting out the word that we're almost done. Senator Young.
Thank you, Chairman. Well, I welcome our panelists, and I'll begin with the topic of telehealth. Even prior to the pandemic, I heard from my constituents in Indiana, particularly those in rural areas, about the ways in which telehealth can both increase access to underserved Americans and reduce healthcare costs. Since the start of the public health emergencies, telehealth flexibilities provided by Congress and the Health and Human Services have been a lifeline for vulnerable seniors. I've seen it up close and personal. It's amazing how we've been able to leverage telehealth to provide vital services to our seniors in particular. But others have taken advantage of this as well to access all manner of care from the safety of their own homes. Currently, authorizations that are included in the CARES Act to create additional flexibility for patients and providers using telehealth only extend through the pandemic. So I'll ask some questions of Dr. Murali. The federal government has relaxed, waived, added, or changed many regulations to expand access to telehealth during COVID-19. What regulatory flexibilities are key to providing telehealth today and should be made permanent after COVID-19?
So I personally think that all the telehealth waivers that came in during the pandemic need to be extended with particular focus on behavioral health, something that you have been a strong proponent of, and looking at what's happening in rural geography. And I'll share a story of a 63-year-old farmer who had to sell all his cows and would not come into our institution for psychiatric care if telehealth was not available. So it's fundamentally important to extend that. In terms of the acute care without walls, that is something that we've all invested in, and we know it works very well. The outcomes from the standpoint of fall prevention, the outcomes from the standpoint of recurrent infections, length of stay, cost of care, safety, patient satisfaction, patient acceptance rate is all phenomenal and off the chart. And that is something that should be extended beyond the pandemic. So those are two things. And then in terms of the geographic site requirements, I think that that also has to be removed because the geographic site requirements restrict care. So it doesn't make sense that a Medicare Advantage patient can go to an MSA and seek care, but a Medicare fee-for-service cannot go to the same location and seek care. So it works for one, it doesn't work for the other. So there are several of these waiver programs that just need to be disposed and done with. And if there is prospective payment mechanisms for groups that are taking risk or capitation, they will figure a way of how to manage the cost of healthcare within the budget that they allocated, but actually making sure that the outcomes and quality are tied to the provider who's providing care. So you want to take the middleman out of the equation and say, physician groups, care delivery groups, you are responsible for delivering on this, and this is the expectation, and they will deliver. Because if you have front-end money to invest on that, we can provide care creatively, just as we did during the pandemic. And so,
Yes.
things that we would support.
So you've just provided a very concise and compelling tutorial on the extension, I think, of these waivers. I appreciate that. Just from personal experience, I have visited mental health providers, and they've indicated to me that not only have they seen an increase in the rate of maintaining appointments, which increases their efficiencies, but there are certain individuals for private reasons that would prefer to have their initial consultations, or in some instances, all their consultations through telehealth, irrespective of the public health conditions at a particular period of time. The providers are generally very happy with the ability to provide telehealth. It took a period of time for many of them to become used to it, but one could envision hybrid services. Here again, even for those who have access to or are able to physically go into the office. But there's just so many efficiencies, conveniences to the consumer as well as to the provider that can be realized here. And as we talk about bending the cost curve down, we've stopped talking about that because we've utterly failed for a number of reasons. Number one, I don't think we've invested enough in prevention across a number of different areas. But this is another area where I see just, sort of a fertile opportunity to reduce the actual cost of care and therefore reduce the cost of insurance for my constituents and others. So very important. Thank you for your quick summary. How much time do I have left, Mr. Chairman? It looks like 30 seconds. And so for that reason, I will yield back the balance of my time. Thank you so much.
If my colleague, because he's the last one, had a last question, I don't want to see him stifled, but if
I have a vote to cast, but thank you for your kindness, Mr. Chairman.
Great, thank you. All right, I believe we've heard from all of our members. I've got a brief opening statement, but I always like Senator Crapo to have a chance to do one as well. And Senator Crapo, would you like to go now?
Well, certainly, I'll be very brief, Mr. Chairman. Again, thank you for holding this hearing. And I thank our witnesses. I think we've had a very strong support for a number of the provisions that you and I, Mr. Chairman, think we need to address on a permanent basis, particularly telehealth. I appreciate your helping us confirm what the issues are and what the benefits are of making that move. And Mr. Chairman, I turn it back to you.
Okay, let me say thank you to all our witnesses. Back in the days when I was director of the Great Panthers, we dreamed of being able to tap the technology treasure trove that exists today. It's extraordinary what can be accomplished. And you all made so many important points. Certainly, this question of equity is fundamental. I would probably say telemedicine during the pandemic was a godsend for people who could get access to it. And you all have made a compelling case that a number of people couldn't. We started, I guess, 3 hours ago. Dr. Davis, you and I were talking about the importance of making sure that audio-only telehealth was expanded. I also share your view about the fact it ought to be accessible in other languages as well. And you could hear the strong sentiment from my colleagues of both political parties on that, because, audio only can be a lifeline in rural communities and communities of color where access to telehealth is limited at best. We also got a lot of good recommendations. Dr. DeCherry made the recommendation to allow permanent waivers for a hospital at home. Strikes me as a very good suggestion. I think several of you made the point that it was time for Congress to remove geographic site restrictions on telehealth. I think you, Dr. Davis, and maybe the good souls at GAO recommended that, but several of you said that there really wasn't a substantive case for doing that. And Dr. Murali, off in the corner of my screen, really brought it home when he said there's no place like home for American healthcare. And probably if Americans could have heard the views you were giving, you would have gotten a digital standing ovation for that one. Now, in terms of the challenges, I was really struck when Dr. Berenson described several hours ago this process of billing and approvals bouncing from office to office to office, leaving both patients and providers in something resembling a bureaucratic never land. And Dr. Berenson, you and I have known each other for a lot of years. We've appreciated your good work, but we would like to conscript all of you good people into this question of sorting out the bureaucracy. And Senator Crapo and I have made this kind of a special priority, because if we're really going to get it right and squeeze out every bit of value for both patients and providers as well as taxpayers, we got to sort this out. And I will tell you, Dr. Berenson, you brought it home, because I've been hearing that at home too, is that, billing and approvals and the like, because this was something that was put together so quickly. And that's another story, because then Chairman Hatch and I thought it would have been done well before the pandemic, because the Chronic Care Act passed in 2017. It was stood up very quickly. And when you painted that picture of billing and approvals, and it was almost like the day when I ran the legal aid office for the elderly, and we just bounced bill after bill and program after program from office to office. And eventually they said, well, Ron's going to run it down. Well, now Senator Crapo and I are going to do this together. We're going to sort this bureaucracy challenge out, and we're going to conscript all of you. But it's been a terrific panel. In my time in public service, we've had a chance to talk to a lot of thoughtful people, and we managed to get everybody together who's thoughtful this morning. So big thanks. And with that, the Senate Finance Committee is adjourned. Excuse me, one bit of business for members. All questions in writing for our guests are due a week from today. And with that, the Finance Committee is adjourned, and we thank you all.